we are about to start the third day of Eternal Heart Conclave. I would request everyone to please take your seats as we are starting this conclave in next maximum 5 minutes. Thank you.
सर आगे ना ठीक ठीक ऑनलाइन है पीछे से प्रभात भाई ऑनलाइन पीछे से हाँ ऑलमोस्ट 30 मिनट्स लेट तो आराम से कॉल कर बोलिए नहीं
हेलो
स्पीकर के पास मत
नहीं तो क्या
सर वहाँ पे भी ऊपर अनाउंसर करते हैं उनके पास बस मत जाओ स्पीकर के पास ठीक है
हेलो 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 ठीक है
बड़ा वाला वो उठा देना बड़ा वाला संजय सर को दे देना
Check. All right, so we are about to start today's conclave. We request everyone to please take your seats. कॉल कर लो स्टार्ट कर दूँ ठीक है
जो सीबी मिला ये हम लोग यहाँ पे सेशन के लिए नाम है
सर विजय पाटिल सर
विजय पाटिल जी बाकी है तो आरमंत्री भैया पिंटू नाटा इनको मिला दो आरमंत्री हैं इसमें से इनके नाम तो अनाउंस कर दो डॉक्टर विजय पाटिल नहीं है डॉक्टर आरमंत्री डॉक्टर पिंटू नाटा और डॉक्टर दीपेंद्र भटनागर इनकी इनको मिला दो
डॉक्टर दीपेंद्र भटनागर और डॉक्टर पुनीश
डॉक्टर दीपेंद्र भटनागर की बजाय इनको मिला दो
पुनीश सेडाना आपने बताया
पुनीश सेडाना बताया
ठीक है बाकी सर बाकी नहीं है और नहीं है तो नहीं मिला अनाउंस तो कर ही देता हूँ नहीं होंगे तो कोई दिक्कत है अनाउंस तो कर देता हूँ Good morning, everyone. I welcome you all in our third day of 6th Eternal Heart Conclave 2024. 2 days, immensely interactive, immensely knowledgeable, and we are going to experience the same on the day 3. For the first session, I would request the chairperson and the panelists to please join us on the dais. To begin with, Dr. Sanjeev Sharma sir, Dr. Vijay Patak sir, Dr. R. Mantri, Dr. Pintu Nahata, Dr. Deependra Bhatnagar, Dr. Punish Sirana sir, Dr. Praveen Sharma sir. I would request everyone to please join us on the dais. Thank you so much to the panelists for joining us. I would request Sanjeev sir to take it forward from here. Thank you.
Yeah, good morning, everyone. It's day 3 and also Sunday morning. So most of the people are in a Sunday mode, then they take a little extra time to come for the meeting and all those. And also today is a Karwa Chauth. So people who are from outside, they want to go back well in time. So for today's, we have a very excellent sessions by the international speakers in a Learn from Master session that will start from 10:30 till 1:30 p.m. And to begin this day, we have kept your tower workshop for all the interventional cardiologists, those who are interested in structural heart intervention, because this is picking up very fast. And we need to know how to plan the tower and what are the basic steps. And because the planning is the key, that's the most important part. And for that part, to assess the three-dimensional analysis of the tower assessment and also nitty-gritties of the every step, we need to have an in-depth assessment and knowledge. And for that, the first speaker will be Dr. Prashant Dwivedi. He's the director of structural heart program and at our hospital, and he's been doing a fantastic job and proctoring the cases all over. So over to you, Prashant.
Thank you, sir. So good morning, everyone. And so today, can you switch on to? So today, I'm going to show how to do the step-by-step three-dimensional analysis to get a proper planning, especially for the transcatheter aortic valve replacement. I'm not going into detail about the mitral valve, TMBR, and other valve CT planning, but I will go in detail about the step-by-step three-dimensional analysis for the transcatheter aortic valve replacement. So this is a three-dimensional system. So basically, whenever you have a three-dimensional system, so there is you have to upload the CD first, and then in that you can select the patient, which patient's CT analysis you want to do. Then once you select it, then it will open in this way. So what exactly is going on? There are 3 different views: coronal, sagittal, and axial view. So there are 3 different views, and what we need to do is we need to select the aortic wall and systolic phase. The reason behind aortic wall and systolic phase is we need to measure the measurement will be taken place from the annulus. So what I am going to do is I will select the aortic wall and systolic phase. Once I will do it, then so I'm going to do this in an automatic way. So once you do it, what system is doing is system automatically selected the central line in all the 3 view: coronal, axial, and sagittal view. And if you have any doubt that if the line is not in the central, then you can adjust it according to by your cursor. So this looks almost central in the all the 3 views. Once you are done with this, then you need to just define the annulus plane. So what I'm going to do is I will go up and down. So first and foremost thing is to define whether the valve is tricuspid or a bicuspid. So if you look at this, I'm going up and down. So this you can see there are 3 different commissure. So 1, 2, and 3 different commissure and 3 cusp. So this is a tricuspid aortic valve. Now I have to define the annulus. So what I'm going to do is, this is a empty pink dot. I'm going to bisect the sinuses by this dot. So what I'm going to do is, so there are three different sinuses. One is, this is the left sinus, this is the right sinus, and this is the non-coronary sinus. How to define whether this is left, right or non? So basically, if you look at this area, if you look at this one, so this is basically RVOT. So whatever is towards the RVOT, this is the right coronary sinus. And what is on the left side is the left sinus, and this is on the right non-coronary sinus. So what I am doing is, whatever I am doing over this angle, the same thing will be reflected on this angle. So you can see that I am bisecting the left sinus from the mid part, and here this is the left sinus. And once I am done with this, what I am going to do is, I am going to select the nadir of all the three sinus. So this is the nadir of the left coronary sinus. So I will give one dot over here, and then I will slowly come down. So when I am coming down, the cursor is moving towards on the nadir of left coronary cusp, and then you can see that I got the nadir of left coronary, nadir of right coronary cusp. I will come down, and it will give us a green dot. So that one was for the left, and the green one is for the right coronary. I will again go up, and once I am going up, I am bisecting this sinus again towards the non-coronary cusp. So this is how I am bisecting the non-coronary cusp. So this is now the non-coronary cusp, and now I am selecting the nadir of non-coronary cusp. So this is how the annulus is there. So if you look at this, we got the three dots, red, green and yellow dots. So this is the nadir of left cusp, this is the nadir of right cusp, and this is the nadir of non-coronary cusp. Now, so basically annulus is not a true anatomical landmark, it's a visual landmark which we define by the CT scan. So what is the annulus? It's a nadir of all the three cusps, and we combined all the nadir of all the three cusp nadir. It will give us a geometry of in the form of circular geometry or the oval shaped geometry. And this will be our annulus. So what I am going to do is, I will confirm it. So once before confirming, I will rotate my cursor towards the every nadir, and I will look whether I am definitely at the nadir or not. So what I am doing is, I am rotating it, and you can see when I am coming at the nadir of left cusp, my cursor is already on the nadir of this cusp. So we have to confirm it in all the three different views. So you can see my cursor is moving just at the level of nadir of all the three cusps. So once I am happy with the position, I will confirm it, and the system automatically will convert it into a stage phase and the coronal phase. Once I am done, there are two different ways to measure the annulus. You can do it manually, or you can do it in automatic way. So I suppose if there is automatic way is available, then we can just select it, and this is my annulus. So this is the most important part to assess the CT scan during the transcatheter aortic valve replacement. The reason behind is because this annulus measurement will define what will be your type of valve and what will be the size of the valve, and what other measurements will be in respect to this annulus. So this is you will get a few measurement: minimum dimension, maximum dimension, average dimension, area, perimeter derived diameter. So I can add it to the screenshot report also. So suppose this is LVOT, and this is I can save it. Similarly, I can save the annulus also in my report. So this is how I am going to do it. So we have measured the annulus, we have measured the LVOT. Now I am going to measure the sinus of Valsalva. So I will go up, and you can see now I am at the broadest part of the sinus of Valsalva. So I will select this broadest part. So and then I will measure the sinus of Valsalva width. So this is the left coronary left sinus of Valsalva. So it's somewhere around 30.6. Then this is the right coronary sinus of Valsalva, and then I will measure the non-coronary cusp sinus of Valsalva. So this is how we will get measurement for the left, right and non-coronary cusp, and we can add it into the report and Once we are done with this, then we will measure the coronary height. So to measure the coronary height, I will go again at the level of annulus, and then I will rotate the cursor. Once I rotate the cursor, you can see this is the left coronary arising here. So I am going to go up, and then you can see, you can also can see where exactly the left coronary, left main coronary is joining the left coronary curve. So you can see this. So here you can see that my left coronary has joined the left coronary curve. So this is the coronary height, left coronary height. So we have to measure the lowermost portion of the coronary height. So this is the left coronary height. Then similarly, we will go for the right coronary artery. So on this view, you can see this is the right coronary artery which is arising like from here. And this will be my right coronary artery height. And we can save it into the report. Once we are done, we will measure the STJ. So STJ is just at the junction where the sinus of Valsalva becoming the ascending aorta. It becomes a circular, and then you can measure it. So in a two orthogonal view, and it will give you the average dimension of STJ. You can add it into the sinotubular junction. Once it's done, you can measure the ascending aorta. Usually at around 40 millimeter we measure. So this is how I am going to measure the ascending aorta. Once we are done, then we will have to measure the coplanar angle. So how to measure the coplanar angle? I just click on this point that's showing the fluoroscopic marker. So once you do it, you will see one eye-like picture. So you just need to bring that eye picture and this arrow exactly at the level of green dot. So basically you are looking from the right coronary cusp, and both similarly at the same time you are looking at the left cusp as well as you are looking at the non-coronary cusp. So this will give you an angle where all the three cusps will be at the same line. So once I did it, you can see that all the three left, right, and non-coronary cusps are in the one line. So this is my coplanar angle, LO4 and cranial 2. And similarly, at this same time, I can measure the angle also. What will be the aortic root angle? Whether the aortic aorta is horizontal or it's non-horizontal. Usually, up to 50 is non-horizontal. 50 to 60 is mild. 60 to 70 is moderate, and more than 70 is severe horizontal aorta. So this is coplanar angle as well as the horizontal aorta. This is how we have done the aortic root three-dimensional analysis. Then once we are done with this three-dimensional analysis at this point of time, we can also look at the calcification. So you can see there is a mild to moderate calcification is there. You can save it also. Then you can measure the calcium quantification also. So the system automatically give you the calcium quantification, and you can see that system. So system itself is saying this, the calcium score is around 292. So the calcium scoring of three-dimensional analysis and the calcium score in the normal CT scan analysis is different. Once we are done with this, then we can do the membranous septum length. So membranous septum length is usually measured in the diastolic phase. So how to measure? We have to select the aortic end diastolic phase, and in the aortic end diastolic phase, we will go into this view, and then we need to see where exactly our septum, muscular septum is arising. So you can see the muscles are arising at this level. So the from the nadir of non-coronary cusp to the junction of membranous and muscular septum this is our membranous septum. So sometimes it has a observer bias. It might, if I am measuring, it might be 7 millimeter. If someone is measuring, it might be 6.5, 7.5. But any measurement less than 3 millimeter is high risk for requirement of any pacemaker. So we can we can label it in our report. Once we are done, then we need to look for the iliacs and femoral. So I selected the femoral, and then I will increase the width of area. Then I remove other parts, and then system automatically saying segment the vessel. So I just need to click once here. Once I click here, it will automatically segment the vessels and remove all other things. Then once we are done with this, then we need to define the central line. So we need to give 3 dots, one into the aorta, another into either SFA or a profunda, and once we are done, we can, so system automatically give you all these 3 measurements. And once you are, then we need to confirm whether our line is central or not. So this is how we are confirming this, yes, this is a central line. So we will confirm it. Once we are done, then you can measure the height, measure the iliacs, common iliac, external iliac and the femoral at different level. So this is how we are going to do it. This is the aorta. This is bifurcation, and here it is bifurcating into 2 different arteries, bilateral common iliac artery, and here we can measure the iliacs. So you can see. So this is how we will measure the common iliac artery, then we will measure the external iliac artery. We will measure the common femoral artery. These all measurements are important for the proper planning of during the transcatheter aortic valve replacement. So this is how we have measured it, and we can save it into the report. So I just, for the sake of time, I just measure on the right side. And then once you are done with this, then we need to generate the report. And once you have saved all the things, you can see that everything has been automatically comes into the report. So now we know that this is the annulus, this is LVOT, this is sinus of Valsalva, left coronary height, right coronary height, STJ, ascending aorta, coplanar view, then calcification, membranous septum, and the iliacs and femoral. So this is how we usually generate the report, and based on this report we need to decide what kind of wall, what size of wall, what route, whether we have to go from the right axis or the left axis, whether we have to use any is there any we have to anticipate the complications, and what will be the bailout for that complication, what hardware you will require. So all these planning and anticipation are based on these annulus measurement and this three-dimensional CT analysis measurement. I will stop at this point of time because we are already running late. If we have any question, we can discuss.
Good presentation. Now, with 3-Mentio, we have to do CT angio, right? Now, there are situations when creatinine is very high.
Sorry, sir?
High creatinine patient.
Yes, sir.
So, if we can't do CT, are there other modalities to plan TAVI?
So if there is a patient is already having a CKD, creatinine is high, so it depends on how much is the creatinine. If it's eGFR is okay, somewhere around more than 50, I still try to get done a CT scan with a contrast, with a low contrast. Because if you get done even a 30 ml, 40 ml contrast and a good picture of annulus, that is the best, because all the measurement, everything depends on the CT scan. So if the eGFR is more than 50, I still go with a low contrast CT scan. But if the eGFR is less than 30 or somewhere like a CKD situation and patient is not on any dialysis, in those situations what we do is we do a non-contrast CT, along with we do a MRI, and then we do a CT MRI co-registration. And based on this, because the CT will pick up the calcium part and the MRI will pick the soft tissue part, and then we do a co-registration of CT and MRI. And based on these, we will do the planning. And third thing is, in this situation, we usually do the transcatheter aortic valve replacement under TE guidance, so that under TE we again measure all the measurement by the 3D TE.
There are reports of using IVUS to do tower.
Yeah, so there are certain reports, but still it's not validated as of now for the proper planning, because we need still a long way to have a proper validation because CT scan is the gold standard. And that IVUS is equal to CT scan or not, it's not been validated as of now.
Dr. Prashant, what is the minimum STJ height to avoid complications associated?
So, sir,
Criteria.
So there is no specific landmark for the STJ height because every patient is different. Every annulus is different because some patient will require only 20 mm wall, but some patient will require 32 mm wall. Sorry. So STJ height is per se is not the importance. It's important is what is the annulus, what is the LVOT, what is the sinus of Valsalva, what are the coronary height. So STJ height is basically more important for the whether there is an anticipation of coronary obstruction or not. So coronary obstruction risk are basically defined by the sinus of Valsalva and the coronary height. These are the two most important parameters. So if sinus of Valsalva is more than 30 and coronary height is more than 10, we are 90% sure that there will be no coronary obstruction until unless we are using a 30.5 or 32 mm wall. If the coronary height is more than 12 and the sinus of Valsalva is more than 32, we are 95% sure that there will be no coronary obstruction. But still, sometimes the coronary leaflet length is more. Suppose it's a bicuspid wall. So sometimes the coronary leaflet length is high, or the leaflet calcification is tip of the leaflet is having a chunk of calcification. So despite sometimes more than 32 mm sinus of Valsalva, despite coronary height is 12 mm, still there might be a risk of coronary obstruction because of the left leaflet length, or there is a chunk of calcium sitting on the tip of the leaflet. So that's why we need. And third thing is STJ. We also need to measure the STJ to have an anticipation that whether if required we can put a stent or not.
Any role of STJ height in valve and valve?
Sorry, sir?
Valve and valve.
So in valve and valve situation, what we need to measure is, it's not the STJ height per se, it's basically valve to coronary distance. So basic problem with the valve and valve is, it's only one major complication is coronary obstruction. Because most of the time surgeon put the valve slightly higher. Once they put the valve slightly higher, so the distance between the left coronary artery or the right coronary artery from the annulus is usually minimum. So but we are not concerned about whether the coronary height is, how much is the coronary height. We are more concerned about what is the distance between the outer frame of the prior valve and the coronary artery. So if it's less than 3 mm, there are chances that the patient might develop coronary obstruction. If it's 3 to 6 mm, it's a borderline situation. But if it's more than 6 mm, we are pretty much sure that there will be no coronary obstruction, despite we are going with any of the valve.
Yeah, very nice overview, and you have explained in detail. Dr. Pankaj Mandoria has a flight, so
Yes.
10:30 we'll have to pass on to him.
Yes, sir.
So in brief, you can go to the large bore axis, and then I will explain the basic steps, and then by the 10:30. So 15 minutes you can cover up, if possible,
Yeah,
about the city planning also, and large bore axis. You can summarize it.
ये डिस्कनेक्ट कर दो ये वाला. Open. So I will go with about the large bore axis. So nobody wants this situation in their lab. So any complications can happen in any lab, but the chance favors the prepared mind. We need to anticipate the complication, and we need to have a bailout strategy, and we need to have hardware in our lab to bail out in such sort of scenario. So why this vascular complication is important? Vascular complication can happen in normal coronary angioplasty also, coronary angiography, angioplasty, or even in the large bore axis. The larger the size of sheath, more the chances of complication. So there are different types of complications can happen. It could be dissection, it could be perforation, there might be a rupture of the artery, or there might be acute vessel closure. So there are certain factors which are more, which governs the vascular complications. So there are certain device-related factors, certain patient-related factors, certain operators-related factors. If you talk about the device-related factors, sheath to artery ratio is one of the most important factors. And if you, so larger the sheath size compared to the normal, compared to the size of the vessels, patient's vessel, it's one of the most important factors where the complication starts. Then patient-related factors are if there is any circumferential calcium or severe tortuosity, or the female patients. These patients are more are prone for having more vascular complications. The operators factors are basically if there is a failure of percutaneous pre-closure device failure, or there is it's in the early stage of the learning curve. So prevention is the key for the best practice. So what we need to understand is we need to have a proper CT scan assessment to guide the access selection. We should do the ultrasound guided puncture. We should have a micropuncture vascular access, and we should do a fluoroscopic confirmation before going in. And then adequate pre-closure is important, and use of appropriate wire and catheter for the delivery is equally important, and we need to maintain the access if there is any catastrophe happens. And the post-deployment assessment is equally important, because if suppose you are done with the case, you close it, and then after 1 hour, 2 minutes, patient might develop a hypotension, and there might be some retroperitoneal bleed. So post-deployment assessment is equally important. So if we look at the data, in 2012, there were almost 29 to 30% rate of vascular complication rate. But now in year 2019-20, it has come down to almost 2.53% vascular complication. So over a period of time, this has happened because of the reduction in the sheath size, ultrasound guided access, micropuncture assisted access, as well as the increased operator experience. So when we talk about the large bore femoral access, there are three important parts. One is entry into the artery, another is the navigating within the artery, and third one is exit strategy. For the entry into artery, we need to understand what is the luminal dimension and how much is the sheath to artery ratio. Then we need to understand, is it a high bifurcation, low bifurcation, or is a normal bifurcation. Then we need to understand the short common femoral artery, whether the size of the common femoral artery, so distance between the bifurcation of the common femoral artery and the inferior epigastric artery is equally important, because we will have a shorter landmark for getting access during these patients. And then we need to understand whether there is a calcium at the level of common femoral artery. So these all are important at the, for the entry into the artery. To navigate within the artery, we need to understand the tortuosity, calcification, vessel caliber, and location of anticipated problem. Then about the exit strategy, we need to understand whether our pre-close is deployed properly or not. Is there any need of any bailout strategy, and if the bailout strategy would be easy, or we will require any vascular surgeon. Heparin reversal is required or not, bailout, balloon tamponade, covered stent, non-covered stent, that we need to be in our mind before going in. So to understand the vessel oversizing, what is vessel oversizing? So basically it's the sheath to femoral artery ratio. Suppose a minimum femoral artery diameter of a patient is 5.5 millimeter, and if we are going with a 14 French sheath, inline sheath, suppose it's if evolute pro plus wall, and if we are going with a 14 French inline sheath, so which is inline sheath 14 French, but its outer diameter is almost 18 French. So it will be somewhere around 6 millimeter size. So sheath to artery ratio is basically 1.09. So it's almost 9% overstretch compared to the patient's vessel anatomy. So there are different expandable sheaths are now available. So if it's a 14 French sheath, so the outer diameter is somewhere around 5.8. If it's a 16 French sheath, outer diameter is 6.5. In this scenario, the sheath to artery ratio is 1.05. But in the similar patient, when we go in and once the sheath expanded, the sheath to artery ratio changes to 1.4, because the sheath is going to expand. It's going to give a stretch to the common femoral artery. So similarly, if you look at the my wall, so for the 20, 21.5, 23 and 24.5, you require a 5.5 millimeter of common femoral artery vessels. But if you, for the 30.5 and 32 millimeter, you will require a more than 6.5 millimeter vessel. So, but similarly, all the three scenario can be deployed with a 14 French sheath. But if we don't have a python sheath or a 14 French python sheath, which is expandable sheath, how much size of sheath will require? It will take a 22 French sheath for the 2022 and 2023 and 26 millimeter valve, it will require 24 French sheath for the 29 millimeter valve. So it's all depends on how much sheath size, what is the sheath size and what is the sheath to artery ratio. Because of all these things, the vascular complications happens. So if you look at this, if the sheath to artery ratio is minus 15%, the rate of vascular complication, major vascular complications is less than 5 to 9%. But if the sheath to artery ratio is even a plus 3%, lead to sudden increase in the rate of vascular complication. So proper CT assessment is important because we need to understand the vessel size, calcification, tortuosity, thrombus, dissection. So if we look at this, this is the common femoral artery and this is the bifurcation and this is the inferior epigastric artery. So this is our the landing zone. So this is the puncture side where we need to get done an axis, and our puncture has to be anterior puncture and the middle of the common femoral artery, and it has to be in between of these two. So sometimes we can so look at this diagram. So you can, this is the inferior epigastric artery and this is the common femoral bifurcation. So this is the conventional landing zone which we will get, but functional landing zone will be less than this. The reason behind it, if suppose there is after the procedure, if there is dissection, perforation or anything happens, and if we require to put a cover stent, we don't want to put a cover stent in the SAV, we just want to put a cover stent above the bifurcation because we don't want to compromise the profunda. So actually functional zone is less than the conventional zone during the axis. So we should always get an axis slightly higher above the common femoral bifurcation. So these are the different sort of common femoral artery bifurcation. So if you can see here, the common iliac artery is basically just a 4.1 millimeter. So this patient was not suitable for the transfemoral aortic replacement. In such scenario, we might need to do the other axis assessment like a subclavian assessment or the carotid assessment. Then what about the puncture technique? So there are different puncture technique. It includes a fluoroscopic guidance puncture, pigtail assisted puncture, ultrasound guided access and fluoroscopic railroad, and sometimes we combine the fluoroscopic and ultrasound both. So the micropuncture is the best practice to get a large bore access, because if your puncture is not at the right point, you just remove the needle, press it for 2 minutes, that's it, take another access. So why micropuncture is important? Because if you look at the normal Schrödinger needle, it's 18 gauge needle and the micropuncture needle is 21 gauge needle. So just increase in the 56% of the size, so just increase in the size of 56%, because here the needle diameter is 0.813, while in the 18 gauge needle the needle diameter is 1.27 millimeter. So by just increasing the 56% of the size, you will get a 5.9 fold increased risk of blood loss. So that's why this micropuncture axis is very important. Then if there is a high bifurcation, so this is to define that if there is a high bifurcation, or if you are not sure whether your puncture site is proper or not, take a axis micropuncture axis and get a axis under visualization. So what we are doing it here, we are putting one catheter over here. Sometimes we put a pigtail, sometimes we can put just a normal JR, and then under the fluoroscopic guidance we can take up axis at the middle of the common femoral artery, and it has to be anterior puncture. And then once you are done with the puncture, you have to confirm it whether it's anterior or not, whether it's in the central or not. Then there is a concept of ultrasound guided access. So there are operators to operators difference, but yes, the ultrasound guided access minimize the vascular complications, and if it's possible, do a fluoro plus ultrasound guided access, because combining both the methods will give you the more safety margin. So what am I doing is here is so this is ultrasound guided access. So what exactly we are looking at? This is the common femoral artery, this is the common femoral vein. If you look at the just distal to this, you can see the profunda and superficial femoral artery. So this is the point from where you have to go up, because this is the bifurcation and this is you are just above the bifurcation, you will see the common femoral artery and the common femoral vein. So this is the longitudinal view, this is the coronal view. And then you need to puncture the common femoral artery. It has to be in the center, in the middle of the common femoral artery, and it has to be away from any calcium spicules. So we need to make sure that we are away from a calcium, we have to be in the middle of the common femoral artery, and it has to be above the bifurcation. But the problem with the common ultrasound guided axis is sometimes we usually take the axis slightly more higher, because we know where is the bifurcation, but we don't know where exactly is the inferior epigastric artery. So sometimes we take the axis very high. So that's why the concept of fluoro as well as the ultrasound guided axis is important. So what we are doing it here is we are taking two modality. Here we are taking the axis through the ultrasound guided as well as the fluoroscopic assistance. So it will give us a more safety margin, because if we take an axis by the ultrasound only, sometimes we might be puncturing over here, because we are above bifurcation, but we don't know how much we are above. So that's why it's very important to take axis with the ultrasound plus fluoro guided assessment axis. Then we need to understand the calcification. If there is significant calcification across the vessel, you can use the IVL, or you can take the help of your surgeon. Then we need to understand the tortuosity and calcification, and always do a road run with a normal Teflon wire or thermo wire, that how much is the tortuosity across the aorta, so that you will get to know whether which type of wire you need required, because most of the time, to advance a larger sheath, you require a stiff wire. But whether you require an amplar stiff wire or whether you require a Lundequist, that all depends on the tortuosity, calcification, and how much support do you want. So in my case, suppose there is a tortuosity, lumen, and lumen size is small, and the calcification is also there. So if there is one is there out of 3, I will still proceed. If there are 2 are present out of 3, I will have a careful approach. But if there are all the 3s are there, I will think about the alternate axis. Few points about the proglide. So proglide are usually, if you are using 2 proglide, it has to be deployed in 2 different directions. One is in 10 o'clock, one is in 2 o'clock position. Typically 2 devices are used to access up to 20 to 22 French. If you are going more than 22, the third device has to be there. Or if the one proglide is failed, then you might need to use another proglide. You can do the trans-axillary or the subclavian axis also with a trans-percutaneous manner, with a similarly like in a femoral way, and you can do a proglide later on. So few points about navigating the femoral artery later. So fluoro visualization is important while we are advancing the large sheath. Then any resistance, stop it. Then do the low pressure balloon dilatation, or if there is a calcification, do the intravascular lithotripsy. Be prepared for ipsilateral or contralateral wire access, because it will give you the bailout. If there is a dissection or anything happens, you can immediately go with a balloon. You can do the balloon tamponade, you can do the covered stent. And pre-closure angiogram is important to define what exactly happening at the post-closure angiogram. And be ready with the balloon, stent, graft, and coda balloon. And always take a help of vascular surgeon. So these are some important demonstration of the femoral axis. You can see there is no significant tortuosity, no significant calcification, straight vessel, and good size of lumen, 8, 9, 7.6, 8.2, 8.4, 9.4. So it's more than above the recommendation. Now look at this, severe tortuosity, severe calcification and tortuosity. So to navigate this type of artery, you need a stiffer wire, like a Lundequist wire, or sometimes you might need a 2 Lundequist wire to navigate these sort of artery. So in the same patient, what we did was, we took the axis, then we took a, I don't know, it's not running. So so Lundequist was the key. So
we just summarize. We'll ask Dr. Pankaj to take the next talk, then we'll continue next.
Sure. So I will just finish in 1 minute. So we need to take some stiff wire to advance the sheath across the common iliac, and always take a last shot what exactly you have done after the closure, because this is important, because if you are not doing it, sometimes there might be perforation, dissection, and then there will be a problem. So for the exit strategy, you can use 2 proglide, you can use 1 proglide, 1 angioseal, you can use if there is a lumen is small, you can use a 1 proglide only. If there is a calcified femoral artery, take a contralateral safety wire, and sometimes you might use a dry closer. So this is the last slide. So 1 proglide, if the 1 proglide fails, and if the sheath size is less than 16 French, do a heparin reversal, do a manual compression, and you can use a third proglide or an angioseal. If both proglide fails, reattempt using the double wire technique or a open repair. You can use a balloon tamponade, manual compression, or the covered stent. If residual leak is minor, more than minor, do a balloon tamponade, manual compression. If the residual leak is major, do a balloon tamponade or a covered stent. If stenosis, remaining stenosis is less than 50%, do nothing. Stenosis more than 50%, gentle balloon dilatation plus stent, and vessel occlusion, do a balloon dilatation and stent. So, not going into this. So, my take-home messages are: main axis should be minimum diameter more than 5 mm as a whole, less tortuous, calcium-free anterior wall puncture. Arterial puncture should be middle of the anterior wall at 40 to 50 degree angle. Dissect subcutaneous tissue before proglide insertion. Last sheath should be pushed only after graded pre-dilatation on stiffer wire under fluoroscopy. One proglide, one angioshield give us a better than the two proglide for the prevention of arterial kinking. But both the therapies are equally good. Wire protection from the contralateral axis is feasible and safe, and post-procedural arterial angiogram is must. Thank you.
Yeah, thank you. Very nice presentation on the large bore axis, which is the integral part of all the structural heart intervention and endovascular intervention. We'll take the question later on because Dr. Pankaj has to take a flight. The next to talk will be after Dr. Pankaj Manoria. So Dr. Pankaj Manoria is a very senior interventional cardiologist and is a director of Manoria Heart Institute, and he's doing great at the Bhopal. He'll be speaking on imaging, now a class 1 indication for complex PCI, latest from ESC 24 guidelines. So imaging, Dr. Pankaj, now a class 1. Over to you.
First of all, greetings from Bhopal, the city of lakes. And secondly, thankful to Dr. Sanjeev and Dr. Sameen Sharma and the entire organizing committee for having me here. In spite of showing a clear-cut benefit of imaging in complex interventions, it remained as a class 2A recommendations for many years. But of late, in the recent 2024 ESC guidelines, it has been assigned as a class 1A recommendations for usage in complex interventions such as left main bifurcations or instant restenosis. So why this change, how this change in the guidelines happened? It was all because of these randomized controlled trials such as Renovate Complex trial, Illumine 4, October trial, and couple of meta-analysis. I'll just quickly sum up all these trials. The largest trial was the Renovate Complex PCI trial. It was basically a large Korean trial done in almost 3,000, it was done around, Korean trial, done in around 1,500 patients. All complex patients, they randomized into two categories. One, they did angiographic guidance PCI. In other, they did image-guided PCI. And what they found was the primary endpoint, which was the target vessel failure, was reduced by almost 36% in those patients who had an image-guided PCI. Also, all the subsets were benefit, whether it's left main, chronic total occlusions, bifurcations, long lesions. All these categories were benefit, and benefit was seen both with OCT as well as with the IVUS. The second was the October trial done with OCT in bifurcation lesions. Good randomized trial. The primary endpoint was the incidence of MACE, which was again 30% reduction in the MACE in those patients in which bifurcations was done using an OCT. So clear-cut benefit was visible. The third trial was the Illumine 4 trial, which was done by Ziad Ali et al. Though the primary endpoint was not met, but what they found was when you do image-guided or OCT-guided complex interventions, you get a bigger lumen. And we all know that the bigger the lumen, better is the long-term outcome. And secondly, the chances of stent thrombosis was reduced in this trial. And then the largest trial was a Chinese trial, an IVUS ACS trial, in which acute coronary syndrome, both ST elevation and non-ST elevation MI, these patients, one category, almost 3,500 patients. In one category, they randomized these patients into IVUS-guided acute coronary syndrome interventions, other simple angiographic guide. And what they found was when we use IVUS during acute coronary syndromes for interventions, you reduce the target vessel failure by 45%. Also, not only the target vessel failure were reduced, but the incidence of myocardial infarction, this was reduced for the first time by imaging by almost 37%. So that was a remarkable achievement with this trial. Then the famous meta-analysis by Gregstone et al., in which they found that if you use imaging, you can almost reduce mortality also. And what I can say is, what is more important than surviving or improving patient survival after doing stenting? This is all what we desire in our patients when we do interventions. And secondly, so this is just that I've presented all the trials on the basis of which the imaging was given a class 1A recommendation. So just to give you how imaging is helpful in left main interventions or complex interventions. Imaging is useful in almost all the steps of left main interventions. Such as in this case, in which this is a tight ostial left main, you're not sure whether you have to use a provisional or a two-stent strategy. You're not sure whether circumflex is involved or not. But when you do an imaging pullback from the circumflex, it is clear that the MLA of the circumflex is almost 9. So circumflex ostia is free of disease, so you can clearly do a single stent strategy in this case and no point in doing a complex bifurcation. In predicting branch loss, whenever we are doing a bifurcation stenting, we are worried that if we do a crossover stenting, a side branch can get compromised. But there are certain predictors on IVUS or on imaging by which we can predict that this branch is going to get compromised and this branch is not going to get compromised. Such as this, if you see such sign, this is an eyebrow sign on the L view of IVUS. That means eyebrow means, if you see the carina, it is pointed, hairy, spiky. So if this type of carina is present, this is a marker or predictor of a side branch compromise, because if we do a crossover stenting from left main to LAD, this carina is going to get shifted and the side branches can get compromised. Exactly that thing happened in this case when we did a crossover stenting, the side branch, the carina got shifted because it was pointed, the side branch got compromised. However, we could build this patient by doing a tap stenting and a new carina was restored. So IVUS is very useful in predicting which branch can be compromised in a bifurcation stenting, which is very much helpful. Secondly, you can estimate the exact size of the stents, pod balloon, everything can be estimated with accuracy. So all the guesswork which can be eliminated and everything can be precisely calculated by doing IVUS. Such as in this case, if you see this long lesion, we are not sure what stent distally, what proximally, but when we do IVUS, we know that's 2.5 distally, 3.5 in the middle, 4.5 proximally. Everything can be planned precisely and in doing these such type of interventions. Also, when we do a crossover stenting, sometimes the side branch appears pinched. So again, we are not sure that what is happening to the side branch. Should I put another stent? Such as this case, a crossover from left main ostia to the LAD was done. Side branch is looking hazy, we are not sure what to do. But just do a simple imaging was done. Circumflex was recrossed and IVUS catheter was put in, and what we found that IVUS, the MLA of the circumflex was almost 9. So there's just it was an illusion that side branch is getting pinched. There was sufficient MLA, nothing to be done. So we have rest assured. So this is how imaging gives us the assurance. It gives us the clarity of what to do to side branch after crossover, how to plan our procedures, and every procedure is very helpful. In each step, it is very helpful. Also, whenever we do a crossover stenting, sometimes we see a carina or a plaque shift. Now, with the help of imaging, we can differentiate whether it's a carina which is shifted or the plaque is shifted. Such as in this case, if you see, this is the baseline. When we did a crossover stenting from left main to LAD, now you can see the carina has shifted, the circumflex is reduced. However, we did a final kissing balloon inflation and we could restore the carina. So this is how, by looking at the beam or a cross-sectional view and see a figure of eight appearance, now we show that this is a carina shift and this is how a carina geometry has been restored. So everything we can assess by doing IVUS. This is again just to show you how the geometry was baseline from the circumflex look back, and this was after final kissing balloon. So everything is visible, you see everything, there's no need of any guesswork, and everything can be planned. Also nowadays we desire link-free carina because it has been seen that if the struts of the main vessel stents are in front of the side branch ostia, these are nidus for future restenosis. So now by doing imaging we can be rest assured that there are no link-free, we have a link-free carina, there are no links in front of the side branch ostia. Such as this case, we did a crossover stenting, and when we did the pullback, we found that there is nothing in front of the circumflex. So this is a link-free carina. On the other hand, this case, we see some struts hanging in front of the circumflex. So what we did in this case, we again did a final kissing balloon inflation and remove all these struts and make it a link-free carina, which is the best for reducing restenosis in the side branch from the crossover stenting. So everything is visible, and we can do precisely all the things. Same thing can be visible in OCT also. Also now when we do bifurcation stenting, if we cross distally in a provisional or a non-distal after a DK crash, it has an impact on long-term outcome. And what level of crossing we are doing, again we can identify to a good extent from OCT and to some extent from IVUS, I can say. Such as in this case, we can see this was after a DK crash, during a DK crash stenting. Now here we can see this is a proximal cross or a non-distal cross. We can see that the recross wire, which is away from the distal star. That means it's a non-distal cross, which is what we desired, which can be easily seen with HD IVUS and also beautifully seen with the OCT. You can exactly see which strut we are crossing or which again. So everything is it's very clear which level of crossing is it, because what level we are crossing has an impact on long-term outcomes. Also, once we have done the DK crash, now we have to be rest assured that we have done a good crushing or not. But so if you see, such as in this case, a left main bifurcation with the DK crash was done, so I want to be rest assured that I have done a good crushing of the stents or not. So if you see no struts hanging in the POC, if you see both the main branch and the side branch struts are completely opposed to the main basal vessel wall, that means you have done an excellent crushing. If you don't see this, that means you need a bigger balloon to crush the further stents. So this is how we assure that we have done a good crushing or not. Sometimes we are not sure that we have covered the circumflex, the LCS ostia completely or not. Maybe there are some struts are visible, are not covered. So if we see such circumferential coverage of the ostia of the circumflex, again I'm best assured that I've done a very good job. My entire circumflex ostia is covered with the stents, so that this is a good long-term outcome. Also, once I have done a final kissing balloon inflation, if I see such type of asymmetric carina, that means I have taken a lesser size balloon. I need to upgrade my size of balloon for a symmetrical carina. So in this case, this was with a 3 balloon, then I used a 3.5 balloon for circumflex and a 3.5 for the LAD, then I got a symmetrical carina. So this is how, based on the symmetry of carina, you can upgrade your balloons or upsize your balloon for a better symmetrical carina, which can be seen with IVUS. And again, these all things have a long-term outcome in our patients. Also, once we are doing a tap, what we need to be assured that what is the length of neocarina. This is the main catch. If the length of neocarina is more than 3 millimeter, then we need to change the procedure or convert it into a reverse culotte or a reverse tap or reverse crush. Such as this case, after doing a tap, when we measured the neocarina, it was around 3.5. This is a long neocarina. This can have a poor long-term outcome. So we need to convert these procedures into reverse crush or a reverse culotte for a better long-term outcome. So everything is not visible on angiographically. If we have to use imaging to be very precise about the length of carina, the symmetry of carina, struts are hanging in the left main, we have done a good crushing or not. Everything cannot be estimated just mere on eyes or angiography. We need imaging to answer all these questions. Also, finally, a report card. When we do a procedure, we need a report card. So gone are the days, we can easily see a report card by measuring the MSAs at the final, and gone are the days of 5, 6, 7, 8, which we used to there. Now the era has come for 6, 8, 10, and now we have moved further ahead for 7, 9, 12. These are the numbers we are always aiming at when we are doing left main interventions. Finally, the complications, sometimes we are not sure about the left main ostia is covered or not. We can identify these on IVUS that we have covered the left main ostia or not. Sometimes a longitudinal stent deformation doing left main interventions, particularly ostial left main interventions, are there which can be missed on bare eyes or on angiography, but we can see, such in this case, we can see the longitudinal stent deformation clearly visible, which can cause future restenosis. This can be easily picked up on IVUS. If we miss such type of complications, it can have hazardous for the patients. Also, sometimes during the interventions, sometimes wires get abdominal or behind the stent starts, such as in this case, when we are doing left interventions, you can see the wire went behind the starts. As you can see, even the IVUS went behind the starts, which was not visible on angiographically. But once we do IVUS, it is clearly seen that your wire is behind the stent starts, and even which was picked up by IVUS. So if I do further intervention with this wiring, I can completely distort the stent and can lead to a fatal complication of the patient. Even on table, patient can have stent thrombosis. So such types of complications can only be picked up on IVUS and cannot be picked up on bare eyes or angiographically. So all the complications you can predict, you can diagnose. Each step procedure you can be very precise, which can have a long-term impact on our outcomes. So based on these things, based on these randomized trial, it was given a class 2A recommendation. So just the final words, IVUS or an imaging is not a magic wand. It is not like you have inserted an IVUS and pulled back and everything is going to be managed automatically. You have to interpret correctly and you have to take actions according to the IVUS findings, because studies have shown that if you do a suboptimal IVUS, that means you're doing IVUS but not changing your strategies based on IVUS, it is equivalent to not doing IVUS. It is not going to improve outcome. Outcome will be improved only if you do IVUS optimization after doing IVUS, not thinking that is just like a magic wand you are putting and everything is automatically going to be perfect. So just in the end, I can say there are two types of left main interventionists. Both doing left main interventions, they both go to home at 2 a.m. in the night. The non-imagers may be thinking, was my left main ostia covered? Should I have post-dilated more? Was the stent undersized? Or was there distal haziness? But those who are doing imaging will be sleeping peacefully because they are very confident that they have done good work. So finally, congratulations to all those who believe that imaging can do good in left interventions, because it is being given a class 1A recommendation. Thank you.
Thank you, sir, for the excellent coverage. Just one question.
Yeah.
Because most of the things you have covered very well with the IVUS. In what cases you think that OCT will be better than IVUS? Or do you select OCT in which type of cases like?
I think OCT is better when diagnosing which crossing we have done or not. Link-free canal is seen much better with OCT. Sometimes in intraluminal things I've seen better with OCT, such as plaque prolapse. We are not sure whether it's a thrombus or a plaque prolapse. These intraluminal things I've seen better with OCT. But I think which HD IVUS, which has a resolution of almost 22 microns, OCT has a 15 microns. So this gap is very fastly reducing between OCT and IVUS. But I agree, both modalities are good.
Yeah, thanks, Pankaj. Very nice presentation and nice overview why imaging has become class 1 indication. Thank you very much.
Thank you.
Because Dr. Pankaj has to take a flight, so we have taken his talk before.
Thank you.
And now we have to finish up with the tower workshop. And the next two talk will be one by Dr. Prem and then by myself. We'll squeeze it to 10 minutes so that we can cover up the lost time. And then Dr. Roxana will be having the next talk as a although it's a very important talk for Dr. Prem in CT assessment of tower, and that is the most critical part of, because the tower is all about planning, 75% planning and 25% execution. So it's a very important talk.
So good morning, everyone. So definitely is a CT analysis is the base of the tower intervention, because the 90% of the tower work is being done before in the out of the cath lab by CT analysis. 10% is only the execution of the TAVI. So first of all, that for the TAVI analysis, CT analysis, three benzo has been explained by the Dr. Prashant, and I will just go real fast on the CT analysis. For the CT analysis, the TAVI, there are four major analyses which is being done in the CT: the aortic root and aortic arch analysis, then the peripheral vessels, and the annulus analysis, LVOT analysis. These all are being done on the CT. So why do we need before proper imaging that to see that is the tower is feasible or not, and if it is feasible, by which route, femoral, carotid, or axillary. If we are going for TAVI, which valve we have to use, balloon expandable or self-expandable valve, and what size of the valve, and what are the very high risk features, what are the predictors of coronary obstruction, and if we have decided that we are going with the particular valve, is there a chance of coronary obstruction, and how to be bail out. It all depends on your CT analysis before the TAVI execution. So TAVI CT is being done at the 30-40% of RR interval, and the minimum slice should be 0.5 to 0.6 mm for the cardiac CT scan and less than 1.5 for the peripheral scan. So these are all parameters which we see in the CT analysis, from the valve morphology, from bicuspid to tricuspid, annulus measurement, LVOT measurement, and sinus of Valsalva, sinotubular junction, which we have explained yesterday about all these parameters. I'm just skipping that. So first is as you all know, that aortic valve is tricuspid. Sometime it may be bicuspid. The first step of the analysis is that which type of morphology. First we'll discuss about the tricuspid valve. So after this we can analyze the annulus by the 3-Mencio. And as you all know that annulus is the virtual ring where all the nadir of the aortic root sinus meet at a virtual line. And this is the anatomical view that all the nadir of the right, left, and non-coronary sinus, where is the annulus, where the TAVI valve will sit, and all the sides are on the annulus measurement. And because the annulus sizing is very important, because if we are going to use the self-expanding valve, then it should be oversized around 10 to 30%. If you are using the balloon expandable valve, then the size oversize should be 0 to 10%, according to 90% of cases on the annular size. But sometimes it also depends on the LVOT, calcification, and something else. And LVOT is below the annulus. 1 to 4 mm below the annulus we call this LVOT. And we also measure the size, area, perimeter, and mean diameter, mean perimeter derived area, perimeter derived mean area, so that this is all are being done on the CT analysis, because all depends on the every valve has its own standards, that which type of valve will sit in which type of the annulus. And we have to check the size, sinus of Valsalva, size of the sinus Valsalva, right, left, and non-coronary sinus of Valsalva is very important to predict the coronary obstruction. And sinotubular junction is the point where all the sinus meet to the aorta. So the size, height, all the very important to predict the future complication for the tower. Then we can assess the ascending aorta, from aortic root to the whole of the aorta, aortic arch, descending aorta, and up to the bifurcation. We have to examine, we have to see the calcification, we have to see the angulation, we have to see the any constriction, so that we can plan our TAVI according to that. Suppose there is a huge aneurysm at the ascending aorta, we can send the patient for the surgery. If we are planning for the TAVI, then we will have to take a precautions. The angle of the aorta to the annulus is very important, because sometimes more than 70-degree angle from the aorta to the annulus it's a contraindication for the self-expanding valve. That time we had to use the balloon expandable valve. So all depends on your CT analysis of the aorta also. So that is very important to learn about the bicuspid aortic valve. Although it is a very big topic, but we'll discuss in very brief. About 10% of cases and up to 10 to 30% of cases of our lab is of the bicuspid aortic valve. Why it is different from the tricuspid aortic valve? Because these bicuspid are large aortic valve, and they are a higher calcium burden and very highly calcified raphe, and there may be associated aortic aortopathy. So most of the time it is a type 1 where the right and left fusion occurs, and 88% of cases time the right and left coronary sinus are fused. And this is the CT analysis of this patient. So the first one is the type 0 aortic valve, where there is 2 cusps and 2 raphe. Type 1, where there is a 3 cusp, but one of the cusp is fused, and it could be calcified or it could be without calcification. So this is the type 1 bicuspid aortic valve. The problem is that these all bicuspid aortic valve are associated with the aortopathy, because the dynamics of the regurgitation or aortic stenosis is totally different from the tricuspid aortic valve. So these patients of the bicuspid aortic valve usually have the ascending aortic aneurysm. We have to consider that from the CT scan analysis. So other problem with the bicuspid TAVI is that most of the time there could be an incomplete apposition that can lead to PVL. There could be higher risk of annular rupture, because these bicuspid valves are associated with the higher calcification, and there could be associated aortopathy can lead to an aortic dissection, or there could be higher chances of brain injury because of these patients have the higher calcification, could lead to stroke that can be because of embolism, and there could be higher rate of pacemaker, because in bicuspid aortic valve there is a could be shorter length of membranous length. The main thing is that how we size of the bicuspid is that it depends on the supra ICD. ICD is intercommissural distance at the 4 mm above the annulus plane, and 88% of cases the sizing can be done according to annulus, but sometime in right side you can see that when the intercommissural distance is smaller than the annular, then we have to size according to the supra ICD intercommissural distance. And so how to select valve size? So 80-90% of cases you can use both the valve, self-expanding and balloon expandable valve. But if there is small sinus, small annulus, you can choose the supraannular valve, so that can be effective orifice area could be larger there from the balloon expandable valve. If there is a higher calcification or higher risk of rupture, annular rupture or root injury, we can use the self-expandable valve. And if there is higher chance of pacemaker, we can use the balloon expandable valve. So how to select valve size? Valve size is according to the different valve has different standards. You can see that all the self-expanding valve are sized according to perimeter, and all the balloon expandable valve are sizing according to aortic valve area. So all these are the standard tables provided by the company persons, and you can select your valve size according to area, what is the annular area, what is the LVOT area. Most of the time, if the LVOT area is within the 10% of the annulus, it means that you can select the valve size according to annulus. Sometimes, if the LVOT area or perimeter is more than 10% of difference from the annulus, then you have to also consider the LVOT, that if the LVOT is larger than the annulus, then you have to select that the valve may dip into the LV, so that LVOT area or perimeter should also be considered. So these are standard parameters of the self-expanding valve. And when to protect coronary, I have discussed earlier. So I will just skip this one. And implantation angle is very important. It is the angle where all the 3 nadir of the cusp, RCC, NCC and LCC, meet in a single plane line, means it is the same line. So it is derived from the CT scan, and most of the time it is in the alveocaudal, allocranial, so we can align that. The purpose of this, that we can reduce the contrast, and so that the valve, the TAVI valve, align according to the annulus plane. So these are the implantation. This we have discussed that LV aorta angle, thoracic aorta calcification, ascending aorta diameter, all are analyzed with the CT scans. And vascular assessment, this is a very important part of the CT scan analysis, but because we have to decide that which site is proper for the puncture for the TAVI valve, because the TAVI valve has a large bore access devices, and this is the standard slide that most of the TAVR valve, like Evolute, they need around 5 mm up to 29 mm valve, And for sapien, they need 5.5 mm up to 26 valve. So it means that your peripheral or from the site which we are going to puncture should be more than 5 mm for the evolute and more than 5.5 mm for the advert. So we have to cautiously select that which site which is less tortuous, less calcified, and easily drawn can be right or left femoral artery. So in this case, in example, you can see that left is very tortuous and compared to right, and you will have to see that what is the mean diameter. It should be more than 5.5 mm. If it's concentric, very calcified, we can use IVL, peripheral IVL, so that so that we had at least we should need more than 5.5 mm artery for vessels. So CT scan is very cornerstone in this analysis. So, and last one is the calcium load and distribution. It is friendly or enemy because the calcium load is associated with a stroke, conduction disturbance, PVL, annular rupture, coronary occlusion, vascular complication, and valve under expansion. It's very important to see that where is calcium and what type of calcium it is. So where is the calcium? Calcium is on the aortic leaflets or annulus or LVOT, because LVOT calcium is associated with the high risk of the pacemaker, and annular calcium is associated with the high risk of rupture, and the leaflet calcium is could be associated with the under expansion of the valve. So these we can assess on the CT scan. So I'll skip on behalf of time that. So these are the complications which I have discussed, the tower complications, and so this is very important that if there is uncertainty about the severity of the calcification, if the Augustus score more than 3,000 men and 1,600 more than in women, that valve is very severe, and we can assess from the CT scan analysis. And this is the aortic root. This is the area of interest, and we'll skip on this. This is very important slide. I think what is the mild, moderate, and severe calcification. When there is severe is called when multiple or single calcified nodule protruding into the annulus area, we call it severe annular calcium. And this is the various annulus about the calcium. This is without calcium, this is mild calcium, moderate, and this is the severe calcification. We should always keep in mind about the calcification on the aortic annulus and root. And
can you just summarize the
yes. This is a learning point from me, is that not every patient is suitable for the tower. We have to decide that this patient is suitable or not. We can send the patient for the surgery if they're not suitable for the tower. And we need to assess the risk of aortic root rupture and calcification that can lead to the aortic coronary calcification. And we need to respect the calcium load as well as its distribution across the aortic valve complex. That's all from my side.
Thank you, Dr. Premnathan, for the nice coverage. Now, next up will be Dr. Sanjeev Sharma, tower step by step.
Good morning, everyone. I'll try to squeeze my talk for next 10 minutes only because we are running late. And my job is made simple by the Prashant and Pram both, because tower is all about 75% planning and 25% execution. And the basic steps are, number one is anesthesia. These days we do in a conscious sedation. We don't give general anesthesia, just a local anesthesia and sedation. Access point is very well covered by Prashant, how to take access, which is very vital to have a femoral access, very safe. Third is a guide catheter selection for the crossing the valve. Usually we take a AR2 or L1. Valve positioning, this is very critical. We have to position the valve right at the annulus so that we have proper deployment. And the valve function assessment, catheter removal, closure of incision. These are the headings in which I'll be covering the talk. This is anesthesia, and then access point, guide catheter selection, valve positioning, placement. Majority of the patients, 95%, get TAVR from the femoral route. Transfemoral is the safest route, and this is being followed in 95% of the cases. Only in 5% of cases, we have to take another route, like access are not possible, then we have to go for the transsubclavian, which is the second commonest. And third, we can take a left carotid access also. For the femoral, we need to have at least 5.5 millimeter of diameter for the TAVR, which is safe. If it's less than 5, then it becomes risky. We have to take some other route, like transsubclavian or carotid, or at times we have to take a transcaval access also. This is the journey of TAVR in India. It started in 2004 as the first in human. It was done in India in 2004 at Delhi Scots. Subsequently in 2012, it was on compassionate basis. Special permission was taken. And then subsequently, it was commercially approved in 2016. It started with the Evolut R and CPN XT. And subsequently, my valve was available in 2018. 19 is Evolut Pro, Hydra, and how it is now. Now we have all the valve available with us. And for these are the TAVR success criteria, the precise positioning of the prosthesis, which is the very important step. And we have to assess the reduction in the gradients, mean, peak, and velocity, improvement in the effective orifice area for more than 1 centimeter square, hemodynamic stability, no rhythm abnormality, no PVL or significant AR, angelling of coronary artery, no injury to pericardium, no pre or post-procedural stroke, no vascular or access site complications, and no renal failure. These are the success criteria in which we should go ahead. And about the planning part, the TAVR evaluation is very important, and the most important is 3D contrast gated CT scan analysis, which discussed by the Prashant in very much detail. Need to have a good echocardiography, left heart cath to look at the coronary arteries, and also assessment of the patient frailty. So important point is severity of aortic stenosis, anatomy of the valve, which is bicuspid or tricuspid, aortic valve calcium, annular silent tubular. All these points have been covered by the previous two speakers. We take an access, cross the valve, dilate, and deploy the valve. So increasingly, these procedures are being performed in the local anesthesia and with some sedation, and so the patient can be discharged very next day. And general anesthesia are only selected cases when we have multiple comorbid conditions or then transfemoral access is not possible. In those cases, we go for the general anesthesia. And we need to have antibiotic prophylaxis also. The access is very well covered by the Prashant. Usually we take a bilateral femoral access. For the left side, we take for the taking the pectoral to the non-coronary sinus for the guidance of the precise placement of valve. Left femoral vein access for the temporary pacing. At times we take intrajugular access also for the pacing. And the right femoral access is usually preferred and for the implanting the valve and for the sheath, bigger sheath like 14-French sheath. For the percutaneous puncture, we use a micropuncture needle and the fluoroscopic and also the ultrasound guidance. Take an anterior puncture before above the bifurcation, safe approach, and then we go with the bigger sheath. And how we go for the bigger sheath? Once we are through with the micropuncture needle, we advance the sheath, exchange with the 035 wire, and over that wire, we dilate it and deploy the proglides. Usually we prefer one proglide and one angioseal, and at times whether we need a bigger sheath, we might use 2 proglides also. And over that a 7-French sheath, we advance the stiff wire and then dilate with the 10-French and 12-French, and eventually the sheath which we use for the TAVR, like 14-French sheath, we advance into the distal abdominal aorta, and subsequently the procedure is being done through that sheath. So pacemaker implantation, usually we prefer the left femoral venous access, and the rapid pacing is required for the proper precise deployment of the valve because we need a fall in the pressure. Otherwise, there is a chance of dislodgement of the valve and the ejection of the valve. It also serves as a protection against the potential bradyarrhythmia, so the pacing is required. And for the crossing of the valve, usually we prefer AR2 catheter. At times, when the route is dilated, we take a AL1 catheter and the straight terminal wire. Once we are through with the crossing, we exchange this wire with the 035 long length wire, and over that, we advance the pigtail and take the safe access into the apical part. And then subsequently, we exchange with the Confida Safari stiff wire for the balloon dilatation and the precise placement of the valve. And balloon aortoplasty hardly required in 25% or 30% of the cases, especially in the heavily calcified valve or the bicuspid aortic valve. And we need to place at the higher heart rate so that we can drop the pressure and so we can avoid the dislodgement of valve. And also the balloon dilatation helps in assessing the valve leaflet movement to assess the coronary occlusion at times. So size of the balloon for the pre-dilatation should not exceed the minimal annular diameter toward the annular perforation. And this is how we do it. We pace at 180 to 200, inflate, and then deflate, and the stop pacing. Subsequently, subsequent to this balloon dilatation, now we are going with the aortic valve placement. For that, we advance over the stiff wire, and we have to be very precise in positioning of the valve. This is a dark middle marker we place right at the annular level, and for that, the pigtail is very good marker. Pigtail and a non-coronary cusp right at the annular level. And it also helps in giving us injection and helping us in a proper assessment of the position of the valve. Usually keep us 70-30, 70 in the aorta, 30 in the LVOT, and eventually it becomes a 80-20. And initial inflation is a little slow, so we go slowly, having a dog bonding effect, and eventually we can go a little faster and deploy the valve with the right position. And subsequently, we take the cine angiogram, pigtail angiogram, which to confirm that the valve is well placed, no PVL or no any aortic registration. So exact valve positioning is the most critical step during transcatheter valve implantation, and correct orientation of the valve is usually outer skirts at the base of the valve towards the ventricular outflow tract and open stents towards the aortic side. And all the procedures being monitored fluoroscopically so that we can make a final adjustment before the annular touch. If you want to pull out or get a little deeper, we can do it, because if you see any change in the position of the valve before the position. So we aim at implanting the 1/3 to 1/2 of the stent above the mid-level of the aortic annulus so that coronary access is there. And in a patient with a hypertension, aortic regurgitation, we might pace at a little slower speed for the deployment. And post-dilatation is required in hardly 25% of the cases. We can, if the valve is not properly deployed because of calcium or the bicuspid valve, we might need a post-dilatation, not in otherwise. And usually for closure, we use a 1 ProGlide and 1 angioseal. At times, when we use a bigger sheath, we need to use a 2 ProGlide also. But most of the cases, we can manage with a 1 ProGlide and 1 angioseal. And we need to take a final check shoot from the opposite groin to make the closure has taken place properly. So the big 5 complications are, number 1 is a paravalvular leak, second is the AV blocks, third is the bleeding from the access site, fourth is a stroke, and the fifth is the acute kidney injury. All these big complications, we have to take care and take all the utmost care so that you can avoid all these 3 complications. So we have already covered, and this is how we take an axis, and then we take a pectoral into the non-coronary sinus, and also the temporary pacing from the venous axis, and then position the valve and then deploy the valve. And ultimately, check the axis that closure has taken place, no bleeding from the access site. So this is one of the example, patient with a severe calcific AS, moderate AR, 35% LV, global hyperkinesia. This is the pictorial from the left femoral venous axis into the non-coronary sinus, and also your temporary venous catheter into the for the pacing part. And this is crossing with the AR2 with the straight termo. Once valve is crossed, exchanging with the longer wire, then exchanging with a stiffer wire, dilating with the balloon, and subsequently deploying the valve right at the annular. The dark marker is right at the annulus level, and initial deployment is slow, and subsequently the valve is deployed, and there is no leak, well deployed, and this is the post-dilatation subsequent to that because valve is underexpanded because of calcium. And this is the final angiogram. We showed the well-deployed valve, no leak, coronaries are okay. And LV function also improved on table itself. So tower is a hard team approach. We need to sit with the surgeon and decide about which one is the best, tower or tower. And subsequently, the pre-procedure planning is the most important part. The CT-based, 3D-gated, ECG-gated 3D CT scan plan, we need to do and assess all the parameters which we discussed in the previous 2 talks. And so the careful selection of the patient and the device plays a major role in the success of the tower. And tower and TAVI has become the preferred mode of treatment in vast majority of the cases with symptomatic severes. Thank you very much.
Thank you, Sanjeev, for the excellent cover, and whole TAVI workshop was planned very well. Now we close this session, I think, and we move to next session. It's over to you. Thank you to everybody. Thank you.
Thank you so much to all the speakers, and thank you to the panelists. Now, moving on to the next one, may I request chairperson and panelists to please join us on the dais. Dr. R.K. Modak, sir. Dr. Jitendra Makkar, sir, please join us on the dais. Dr. C.B. Meena, sir. Dr. Vivek Chaturvedi, sir. And Dr. P.C. Raka, sir. We request you all to please join us on the dais for the next one. Thank you. Now may I request the chairperson to please take it forward from here for this session. Thank you so much.
Good morning. I think Dr. Pankaj Manoria delivered his lecture because he has to leave. So straight away I'll invite our most distinguished faculty, Dr. Roxana Mehran, non-cardiac surgery post-PCI, how to manage. So it is like listening directly from horse's mouth because she has been into this for long.
Yeah. Good morning. Thank you, Dr. Sharma, Dr. Manju, for bringing me here. What a beautiful city it is. We had a chance to drive around and see it. And I'm so impressed with all that you all bring here. The topic of non-cardiac surgery post-PCI and how to manage it is a difficult one, actually. Imagine if we were to design a study, how difficult it would be. And I'll try to explain to you why the data and everything that I present to you is just based on observational work. We have some randomized studies, but it's not going. Oh, okay, so this doesn't work? Okay. These are my conflicts of interest, mostly due to research payments to the institution for the work that I do for the Clinical Trial Center. So here's the story. Here's the story about surgery and stents, right? So patients are patients, they all will have some, about 3.5% of our patients undergoing PCI. Oh, sorry. This is, what did you do? Can you go back? Go back, you just, okay, that's good. Thank you. About 3.5% of the patients undergoing non-cardiac surgery undergoing stenting will have some early non-cardiac surgery need. It's only about 3.5%. But, you know, with the volume, for example, that we have at Mount Sinai, and you think about the volume here in India, that's not a small number of patients. And as you remember yesterday in my keynote speech, that first 3 months after the stent, just remember that. The first 3 months is the most difficult time where you will have major adverse events pretty high. Death rates of 4%, myocardial infarction of 5%, and transfusions of 21%. This is a high-risk period. And why is that? Because, first of all, you're withdrawing the protection that's needed in that early stage after stenting, but surgery is also associated with this increase of prothrombotic and inflammatory state with cytokine release and lots of other platelet adhesiveness. So it's a prothrombotic state in a state of incomplete endothelialization of the stent. High-risk period. And it's for this reason that if you look at our guidelines, and it's important to note, if there is a acute coronary syndrome, at index PCI and other high-risk features in that first month, it's class 3. You are not to be doing elective non-cardiac surgery. And even up to 3 months if those features are higher in terms of ischemic events. So it's recommended to wait at least 6 months after elective PCI and 12 months after an ACS. That's the recommendation for the class 1 indication. But class 3, harm in the first 3 months. So don't do it. So here's what we're going to do today. So that's basically what you need to know absolutely for your practice. But these are the 3 things that I want to talk to you about: surgery and ischemia, surgery and bleeding, and that bridging therapy. So just starting with surgery and ischemia, it's really easy. It's absolutely simple. Think about the risk of the surgery. What are the surgery-related risks? Is it a high-risk surgery? And we'll talk about that. And then let's think about the patient's characteristics and what's their risk. So if you have a high-risk patient undergoing a high-risk surgery, that's a high-risk situation. And so it's combining ischemic risk that becomes extremely high. And by the way, their bleeding risk is high too, because those high-level patients will still need their antiplatelet therapies on board or some bridging. So you can imagine it's both ischemic and bleeding issues. So easy to imagine that. What are those high-risk surgical procedures where you have a very important ischemic risk over 5%, adrenal resection, aortic major vascular surgery, carotid surgery, duodenal pancreatic surgery, liver, esophagus surgery, open lower limb revascularization, pneumonectomy, pulmonary liver cystectomy, and as well as perforated bowel. So even those very, very acute abdomen patients, extremely high risk. And the urgency of the procedure is also very important. The more urgent, the higher the risk. And you can see that where the high-risk surgery, you go from low risk to high risk, and the numbers go from 2% up to 8% in terms of major adverse cardiovascular events. And you see that right here. This is over 22,000, obviously observational data, and you see this within 12 months versus control of a PCI, high-risk surgery, high risk of MACE. That's you see that up here, high risk. They fall up there. And it's very simple. When you look at this, this is a very, very important paper in JAMA surgery. This comes on the board exams all the time. Within that, that's where we're getting those 6 months in the guidelines. That's how we wrote it in the guidelines because of this paper. It's up to 6 months. You see the rates of myocardial infarction extremely high, and the hazard of myocardial infarction is kind of there all the way out to 12 months. That's why we say 6 to 12 months for patients. Now, it used to be, let's just give a bare metal stent. Well, this study, Leaders Free, which actually enrolled patients, this is a sub-study of the Leaders Free, they enrolled patients who were expecting to have non-cardiac surgery, randomized them to a bare stent versus a drug-coated stent, which was the biosensor stent, and they actually showed a lower probability of MACE events in those patients undergoing non-cardiac surgery with the drug-coated balloon. So bare stents are out. It used to be, they're going for non-cardiac surgery, let's give them a bare stent. Don't do that. The stent type, absolutely keep it. Now, we also perform a very large-scale 5,000 patient observational data on the Paris registry, and because the entire thing was about adherence to antiplatelet therapies, and we followed patients who needed to either have some interruption or disruption or discontinuation. So discontinuation, the physician says, interruption, the physician-guided interruption, those were the people who had it, like for non-cardiac surgery, and disruption was when you stopped or there was an acute event. And look at those two, interruption and discontinuation, we had no issue with MACE. So under the guidance and under the tutelage of a cardiologist, you could manage this, no difference, or being on DAPT or discontinuing. And you see that right here. The control is on DAPT, and you see we really showed this for the very first time back in 2013, published this in The Lancet. It was a groundbreaking study. Nobody imagined that that would be the case, but that is the case. And then bleeding, very, very important to understand what are those surgical procedures that are at very high risk of bleeding. We do not want a patient to bleed out just because you're worried about their dual antiplatelet therapy. So spine surgery, intracranial surgery, liver, bowel, colonic polyp resection, device implantation, cardiac surgery, spleen, kidney, and urological surgery, all associated with high bleeding. And I'll tell you, these are, again, very, very important. You certainly would not want to have an intracranial hemorrhage or any kind of a neurologic hemorrhage just because you didn't want to discontinue DAPT. And I think it's very, very clear that if you look at this, the perioperative bleeding risk of these patients, within a month, high risk of bleeding and platelet and packed RBC transfusions. You see that, and again, that's another reason why when we wrote the guidelines, we said 6 months at least. Look at these rates of bleeding and RBC transfusions in high bleeding patients. And if you left the clopidogrel on board, look at what is happening here. Ischemic rates are no difference if you didn't have it. And no difference between if you kept it on or you didn't. And many of these patients had it on or off. This is 50,000 patients, 54 studies, all observational, but absolutely more bleeding when you leave it on, in those especially. So think about that. That was for non-cardiac surgery. That was for CABG. This is for non-cardiac surgery and device implantation. Again, bleeding matters, and you have to be thinking about that. So I'll just talk about the before CABG just quickly with why ticagrelor is still like 5 days, even though we know the half-life is a little bit shorter than prasugrel. It's about 5 to 7 days, 3 to 5 days or so. And you can take a look in this and see what's happening. Up to about 4 to 14 days, but from 0-1 to 2 to 3, you start to see a reduction once you get after 3 days, stopping ticagrelor before CABG surgery. And at last, I'll talk to you about bridging therapy. Now, remember, it's again observational. We have a large volume at Mount Sinai, and we were able to publish our work in this journal a couple of years ago. It was a very difficult analysis, so stay with me. This is 747 patients from Mount Sinai, from our cath lab, undergoing urgent or elective non-cardiac surgery within a year after PCI. And we had about 1,600 of those patients, of which 1,285 were on DAPT before surgery. And you see the other people who basically were of the 1,285, 555 interrupted, and a large number, a half of them, we didn't interrupt their antiplatelet therapies. Of those interruptions, we hardly used bridging. It was a very, very small group of patients who received cangrelor bridging, and we'll talk about that. The patterns are different in terms of how things were interrupted, 5 days, 2 days, or even at the time of surgery. But the truth is that on these patients who had their DAPT interrupted, most of them were on aspirin still. Clopidogrel was what was really interrupted. And you see here the rates are of death MI stent thrombosis 30 days after their non-cardiac surgery and DAPT interruption, 3%, 2% death rate, only a 0.9% MI, myocardial injury, just some troponin release of about 9%. And whether you left them on aspirin alone or DAPT, bleeding was basically the same. Aspirin gives you a little bit of bleeding, about 2 times more likely to bleed. When is bridging necessary? It's when there are high-risk angiographic characteristics, high-risk patients, close timing to the fresh stent, a fresh stent. The patient gets their stent, the old lady falls, she breaks her hip, and we have to do a hip replacement. These things happen. That's a high-risk patient. And of course, the kind of stent. And you think about that surgical risk again with their perioperative hemorrhagic risk, the risk of reoperation, and difficult hemostasis. You put that all in the balancing equation, look at the balance, and then you think about how you should bridge. Cangrelor is this intravenous ADP P2Y12 receptor antagonist, quick onset, quick offset. It's a switch on and off. The plasma half-life 3 to 5 minutes. In 60 minutes, you go right back to your normal platelet function when you stop it. In comparison to tirofiban and eptifibatide, which are the potent platelet inhibitions, those are, of course, glycoprotein 2B3A inhibitors. We used to use them. Thank God we have Cangrelor. You see the differential and very, very important data that we have from the bridge trial with Cangrelor showing a great on and offset, onset, and able to go back to normal platelet function. Very, very important just before CABBAGE in the bridge trial, which showed very, very good results. And our review article of sort of saying what you should be doing. Stop prasugrel 7 days before, clopidogrel, ticagrelor 5 days before. You can think about in those high-risk patients IV Cangrelor or eptifibatide and tirofiban. The idea is minimize that unprotected time and go back to reloading clopidogrel, or if you can't, put them back on IV Cangrelor a little bit later. During surgery, they go off, they go back on, you give them back. The idea is this. When you think about Cangrelor versus a glycoprotein 2B3A inhibitor, and you say, why should I use Cangrelor? Because you actually save money. There's money saving, believe it or not, compared to eptifibatide. A savings of about $5,824. That matters. Dr. Manju is watching, and she is watching the pockets here. Here's another very, very important study, the only double-blind placebo-controlled trial of aspirin versus placebo in about 5,000 patients who had a previous PCI who went on to have, and why is it that we insist on leaving patients on aspirin? It's this perioperative aspirin has more likeliness to actually benefit than harm patients who've had a prior PCI. Now, this isn't the very early, these are just prior PCI, but this POISE study just shows you there was a reduction in those important events and it's not that many, you see the number of patients and the risk after all, and it's important to note. So the key summary is timing and characteristics of PCI. All the things in red is that early timeline between 1 to 3 months to 6 months. The patient's age and comorbidity, the older you are, more heart failure, worse kidney function, low hemoglobin, higher level of risk. And of course, what kind of surgery? Is it a bleeding risk during surgery? How urgent is that surgery? Is it a cardiovascular risks of surgery? Anytime you have a high-risk surgery, these are the ones that are high risk. And, of course, very, very important, consider bridging with intravenous compounds when DAPT cannot be interrupted before non-cardiac surgery. It's not that often, but when it happens, consider it when they're undergoing surgery. Thank you for your attention.
Thank you, Dr. Oksana. Any question, quick, one or two? Okay.
Can I ask?
Yeah.
Dr. Mehran,
Yes.
I listened your lecture. It's a very wonderful lecture.
Thank you.
And last two slides, you mentioned, really it is eye-opening for us Indians. If there is any dental extraction, dentist ask us to stop DAPT. And you are telling change the dentist. And if there is a minor or major surgery, the surgeon asks stop DAPT or start low molecular weight heparin, just like that. You mentioned change the surgeon. So how you are seeing this perspective of India?
Well, I mean, I think it's, you have a patient, this very, very clear. These things happen where you have to have these minor surgical procedures. They're extremely common. And if every time you did that and you stopped dual antiplatelet therapy in the patients who are just received the stent, I think it's not correct based on the data that we've had. Now, look, all of those data on the old days, bare metal stents, not good imaging, all these other things, we have to collect more data, but it is what we have. It's what we have today, and I think what's the biggest and most common questions, and you know something, they stop asking now. They learned how to deal with the bleeding issues locally without stopping dual antiplatelet therapies. They used to be crazy when we first started, but now I get less and less calls. When was the last time, Dr. Sharma, that a dentist or a GI doctor called you to stop everything on the patients?
Yeah, no, I mean, it still happen, particularly, I would say here is very common, even in America it does happen, but key is, you're still continuing aspirin. You're not stopping both.
You're not stopping both.
That's the key. In the number one, we have changed what happened to slide again?
Put the slide back up for Dr.
So this is very important. No, actually, this is a very, very important slide for everyone and goes with the guidelines.
Yeah, really.
So you continue aspirin, you stopping your other, agreed? Now second, minor surgeon wants to stop DAP, change the surgeon means you are still continuing one antiplatelet.
One
therapy.
antiplatelet.
So what about bridging with low molecular weight heparin here?
Right. So question is, the base as shared, heparin does not work. Either you go with the 2B3A or IV Cangrelor. IV Cangrelor is available in India now.
Really, this is eye-opening for us here in India.
They're not heparin. I know everybody gives, but that does not work. It is either IV or short duration, one day. I mean, of course, it will take more time for the 2B3A. But key is the IV Cangrelor, if available now in India also, and that is what we do. They showed the 1.1% bridging in the past, but now even in America, that number probably will be 15-20%. But many times you can just stop and start the surgery and post do it. The last one is also important. That's the one. That question is, don't stop aspirin. A lot of people gradually will learn, surgeons, to do surgery on aspirin. Only one with the guideline, they say, if you're doing a spinal surgery.
It's spinal and intracranial.
Intracranial, spinal, then you stop aspirin.
And also ocular. Sometimes
with ocular, spinal, there you have to stop aspirin, and those are the ideal cases of your 2B3A or Cangrelor.
Sir, majority of our dentist friends, they are afraid with the aspirin. And what about neurosurgeries when patient is taking...
That you have to stop both.
That you have to stop.
Both. That you have to stop both.
I already told you that.
Yeah.
I showed that.
Yeah.
Okay, just about the third point here.
I will have all my slides available so you can go back and read all those papers.
Just about the third point.
Yes.
Bridging is more important for complex PCI, which we have done in the past, rather than the surgery, whether it is major or minor, isn't it? Like bridging, I will do if I have done a left main.
If it's early within the first 6 months, you put bifurcation stents, and now you're undergoing a high-level surgery, you really have to bridge that patient. You can't just stop things. And still, with the bridging, you give the aspirin during the surgery.
Yeah, it's
The
very
big
good.
question is now we are switching, want to say, I want to switch, take aspirin away for chronic maintenance is one of the things that we're thinking about. And that's the difficult part, because that is the part that people don't want to operate on P2Y12 inhibitors. And if you have a patient on ticagrelor or monotherapy, you have to switch them back to aspirin underneath when they're undergoing surgery without need to upload or load them with 325 or any crazy thing like that. Now, many surgeons are telling the patients, they call me and they go, Doc, the doctor wants to stop aspirin for 7 days. And then I have to talk to the surgeon and say, please do not, learn how to treat, how to work with the aspirin. And we've been able to get patients through surgery on aspirin.
And it's important that dental association and ophthalmology association, all the surgical associations should endorse this.
Yes.
It should be presented to them so that they
Exactly.
get educated and follow that, because they all are apprehensive.
But now the Indian dental surgeon has started doing at least on aspirin.
Well,
Most
as
of them
soon as
are,
the
yes.
surgeons learn that they're going to have a cardiac complication after their procedure, they'll start operating on aspirin. Yes.
Cangrelor is a little expensive in India.
Yes, yes.
So it costs you 10, 15,000.
Eptofibetide is equally tirofiban, eptofibetide is
You
okay.
can do those, you can use the glycoprotein 2B3.
Yes.
Young dentists, they are used to with aspirin, but older dentists, they are afraid. So we have to, the key of this talk
That's
is
why I
that
said, change the dentist.
change them.
Even the cataract surgery, they ask us to stop cataract surgery. But you can do it on
Cataract
DAPT.
surgery, yeah.
You can do it on DAPT.
So we have to teach, we have to take the more CMEs for dental peoples.
Yeah, so this discussion can go endless.
They could have filled the room. They could have come here and filled the room.
Up to 12 months. It's really very, very high risk. Listen to me. Very, very high risk. First 3 to 6 months. But up to 12 months, we see events, very high. I showed you the data.
So what is the duration of that high risk?
The
You
duration
have first
of
6
what?
months, all right, but we have plenty of patients who undergo all these procedures, even later on. So what about that period?
That what? I'm sorry, what's the question?
Is the minimum duration where you could be safe that stopping the DAPT 3, 6 months or 12 months?
Yeah,
based on the guidelines?
it's really after 6 months,
Yeah.
preferably after 12 months.
Yeah.
Preferably. If you have an elective procedure, if it's elective, wait 1 year. Especially if they got multiple stents, especially if the doctor just did it fast and undersized the stents and didn't do the job they were supposed to with imaging.
Like knee replacement about 1 year.
And after 1 year, the latest trial showed aspirin versus no aspirin.
That showed that, yes, exactly, that some aspirin is still good. So the surgeons have to learn to operate on aspirin. Bottom line. Thank you.
Okay, great. So, 2 improvisations here. I invite Dr. V.D. Meshri sir on dais to accompany us. Please, sir. He is our teacher. Please come, sir. And there is one talk long pending, which is my personal favorite, because being an EP, I need MRI the most. So I'll invite Dr. Ritu Agrawal for how the MRI can be used in cardiac clinical practice. So Dr. Ritu is one of the most renowned cardio-radiologists of the state. So, yeah.
So I'm extremely grateful to be here, and thank you, sir, for your kind introduction. I know we are running late, so I'll be trying to be fast. So CMR is basically a one-stop shop for various cardiac disorders. Now, advantages, it's accurate, it is reproducible. Unlike an echo, you can save it, you can review it again and again. It has unrestricted field of view. There is no ionizing radiation. We can actually look and characterize the myocardial tissue, and it's very safe in renal disorders. Now we have these host of multiple sequences. We have the edema sequence, we have Okay, I'm sorry, can you use this probably? So we have this edema sequence to look at myocardial edema. We have these newer mapping sequence to look at interstitial fibrosis. We have these cine images to calculate the volumes and the EF. We can also do a stress and a rest perfusion using adenosine. And we have this our traditional SCAR LG sequence, which is a powerhouse of cardiac MR, where the normal myocardium is black and whatever is abnormal is white, and it's seen very clearly. So now coming to the first and the foremost application, viability imaging. Now after the stitch and revive, this is actually up for debate, but as of today, we are still doing multimodality imaging for viability assessment. And we have multiple techniques for doing so. We can do it with a SPECT, a dobutamine stress echo, FDG PET and MR. Now, SPECT and DAC are not as good as FDG PET in published studies. So the question comes basically, is it FDG PET versus MR? There are no direct head-to-head comparisons, or I would say a very few comparison studies. And actually both works, but I would still say MR is better because it detects the subendocardial ischemia better than PET. It has a relatively shorter protocol and requires no preparation when we look at PET. It's a gold standard for hibernating myocardium, and there is a good perfusion to metabolism mismatch. It shows a good correlation with that. Now on the slide, when we do a MR, we do a viability assessment, what we are looking for. Anything, a scar more than 50% thickness is non-viable and less than 50% is viable. But then besides that, you see a lot of other things on MR. If you see a dark spot within the scarred myocardium, it is a microvascular obstruction, which is a risk of arrhythmias in patient. You can look at the LV thrombus. Again, you need to anticoagulate and change the management. We can get the RV involvement, which again changes the management. You can look at this intermyocardial dissection where blood is seeping between the myocardial layers, changes the management. We can see this LV free wall rupture with the formation of a pseudoaneurysm and a thrombus on a MR. And we can also, on this slide, I just want to let it come down. We can see there is rupture of the septum. One more. Rupture of the septum, and then there is a post-MI, there is a VSD formation here. So when you do a MR, when you do a PET, you get only viability. But when you do a MR, you get all of these, and each of these changes the patient management. So therefore, I would say MR is actually better. Now we can also do a perfusion, a stress MR using adenosine. And when you see this kind of perfusion subendocardial defects, whereas on scar sequence we do not see a scar, then we know these areas are ischemic and not scarred. Whereas these areas where you see a perfusion defect, but you see a scar on the corresponding distribution, then these areas are scarred. So you can detect ischemia as well as the scarred myocardium on MR, which is not possible on PET. Now, according to the ESC 2023, MR is class 1 level B indications, recommendation for initial evaluation in patients with cardiomyopathy. And we divide them into 5 broad categories: hypertrophic dilated, arrhythmogenic restrictive, and non-dilated LV. Briefly, I would like to talk about role of MR in each of these. So the first thing in hypertrophic cardiomyopathy, MR tells us whether it is really hypertrophy or it is something else. We can look at the pattern of myocardial hypertrophy very clearly and would tell us whether we are actually seeing an athlete's heart or a hypertensive or a valvular disorder or maybe a amyloid and febris, because each of these shows up differently on MR. Apical HCM is a very common indication because apex is not very well seen on 2D echo, and MR gives you a very good estimation, very good diagnosis. Now, MR would let us see the subvalvular obstruction and thus would tell us whether it is hypertrophic cardiomyopathy versus obstructive. Look at the LVOT, whether there is a membrane or something which is causing hypertrophy. This is the classic LG sequence where we can see the degree of scar. Using software, we can quantify these scars and give us as a percentage of scarred myocardium versus the total myocardial thickness. And then these are the mapping sequence, which again help us very well. Now, if you have a myocardial thickness more than 30, or if you have the percentage of scarred myocardium more than 15 to 20% of the total myocardium using these softwares, then these are actually indications for primary ICD, and therefore MR not only allows a diagnosis but also tells you about the prognosis of these patients. Now, when we look at the patient of cardiac amyloid, okay, so I don't know why the slide is not showing. So when we look at the patient with cardiac amyloid, then we have this T1 map which tells us about if the T1 map is abnormal, then the patient has a definite diagnosis of cardiac amyloid, and we can actually diagnose amyloid without a biopsy. I was trying to show this on this sequence. Anyways, so in a DCMP, when we have this kind of patient with the base is contracting, but the mid and distal segment is not contracting, and there is no scar, then we know this is a Takotsubo cardiomyopathy. When there is a ratio of non-compacted to compacted myocardium is increased, then that's a non-compaction. And this is a still image where the septum was dyskinetic, and the patient has a bundle branch block and no scar, so that was a bundle branch cardiomyopathy. So in a patient of dilated cardiomyopathy, MR will tell you whether it is ischemic versus non-ischemic and the different subtypes of non-ischemic, so that you can give a targeted therapy to the patient. If you are trying to go for a CRT and you see a scar, then the patients might not be responsive to cardiac pacing. MR is the gold standard for estimation of EF, so pre and post treatment EF can be estimated, and then again it allows for detection of thrombi and risk stratification in this group of patients. Now, these are the favorites of Dr. Makaran and all the other EP people. When the patient comes with irregular rhythm, the basic questions, query sarcoid, query ARVD, query myocarditis. Now, when you see this patient who has this mediastinal nodes, a fair degree of LV function, and you see this pattern of scar. It is subepicardial to mid-myocardial. It's involving the RB, forming the classic hook sign. Then we know this is a patient of cardiac sarcoid. However, if we see myocardial edema, early enhancement, and late enhancement in a non-ischemic pattern, then 2 of the 3 Lake-Louisi criteria are positive, then we know this is patient of myocarditis. For ARVD, we have these major and the minor diagnostic criteria, which are from ECG, echo, and MR. And for MR, when we have these numbers fitting with the end-diastolic volumes of more than 110 in male per meter square, that's body surface area, and more than 100 in females, and the ejection fraction is less than 40. So when 2 major or 1 major and 2 minor criteria are fulfilled, along with the ECG and the echo findings in the appropriate context, then we can suggest a diagnosis of ARVD on MR. Now we have certain newer trends in arrhythmogenic cardiomyopathy. So now we are seeing patients with biventricular involvement and isolated LV involvement, which are now AL instead of ARVD. They are arrhythmogenic left ventricular cardiomyopathy. So the classic terms is arrhythmogenic cardiomyopathy. So MR will tell you even if there is involvement of the LV, if there is a subepicardial scar in the LV without involvement of the RV. So then it will establish a diagnosis, allows a differential diagnosis from other conditions which might present in a similar manner. It will identify additional family members, can be used for follow-up. And if you have a normal cardiac MR in a patient suspected ARVD, then it is almost 100% negative predictive value for patient in this patient. Now, this is a very common scenario when we have this patient with NSVT or BPCs and they come for MR. And when we see this classic ring pattern scar, you can see the white is almost in a ring. When it has more than 3 myocardial segments, then these patients are actually at high risk, and these patients need a much more closer follow-up and primary ICD implantation. And unfortunately, most of these patients are actually very young, so we need to be very careful about them. Now, coming to the patients of pericarditis, when we see a pericardial edema with pericardial enhancement, Then we know this patient is acute pericarditis. Sometimes with this you may have associated myocarditis as well. So this side of the slide, this patient goes in medical therapy. However, when you see this kind of patients who have pericardial calcification with signs of constriction, then these patients of pericarditis are surgical candidates. So MR again helps us whether or not pericarditis is present. It is pericarditis versus perimyocarditis, and if the patient is acute versus chronic, so that the patient needs medical management or surgical, therapy. Can you just go to the next? Okay. Now, cardiac mass is again a very important application. First question, whether it is a mass or a pseudomass. Then second question, whether it is a thrombus versus a mass, because the management is totally different. And the third question, whether it is a benign versus malignant mass. And the fourth question and the final question, if it is a benign or malignant mass, then what is the degree of extension involvement of the surrounding structures? All these questions are very well answered, and for the brevity of time, I wouldn't go into the detail, but these are the common ones. That is a thrombus in the left atrium, left LV apex. That's a thrombus in the left atrium in a patient of amyloid. That's a classic myxoma LV with the enhancing core and non-enhancing cap. That's a small fibroelastoma. These are difficult to see, but we were lucky in this patient. That's a rhabdomyoma in a young child. And that's a lung mass, and then these bright enhancing spots in the myocardium are cardiac mets. Now, congenital heart disease, MR is the gold standard for estimation of EF, so it will give you the exact size and the function of LV and the RV. It allows to calculate the regurgitant fractions and thus quantify the PR and the timing of the valve replacement. We can calculate the QPQS and calculate the residual shunts and the branch stenosis, and also we can look at the anatomy. The slide briefly shows up all these. So we can calculate the EF, we calculate the surface, we have these flow sequences, we can give a forward flow, backward flow, and then calculate the regurgitant fraction. That is the LP stenosis, and that is a pseudo RVOT aneurysm in a patient who was operated for TOF. So what does MR do beyond diagnosis? It allows for risk stratification, it helps you in planning of treatment, it's a non-invasive follow-up of patients, it helps us in understanding the pathophysiology, it allows in screening of family members, and overall it reduces mortality and morbidity of these patients. So the take-home messages with tissue characterization and evaluation of cardiac function. CMR provides unique information for diagnosis of various cardiac diseases. I would like to take this opportunity to emphasize the importance of cardioradiology as an important integral part of cardiology and CTVS department. And when we improve collaboration, when we talk to each other, the cardiologists, cardiac surgeons, and the cardiac radiologists together can set up new and improved standards of cardiac care. I'm very grateful to my mentors in the Cleveland Clinic for teaching me all the cardiology, and also for the people present in this room, because interaction with each and one of you helps me to learn better, helps me to understand where I made a mistake, and this is a hard-working team that makes everything possible. Thank you so much for your time.
Thank you, Dr. Ritu. Just we have day out question, especially like Dr. Vivek and we dealing the patient with arrhythmias and devices. So what is your opinion? Right? Most of the time you say the MRI compatible devices and all. So what is the problem? MRI, all the ICD pacemakers and all these CRTs, and every time you have to think about that, if the patient has an indication or he may require MRI in the future. So what is your take on that?
So MR is actually good for telling you whether when you want to put a device or not. So like in case of hypertrophic cardiomyopathy, you know if the scar percentage is more than 15-20%.
No, my question is that the device has to be compatible, MRI compatible or not. So what is your take on
Most of the devices these days are MR compatible. Now, if you are looking at a cardiac device, then doing a scan in that patient sometimes is troublesome because of the artifacts. But then again, it is different for different patients. We try and do, and sometimes I personally always call sir. And if a scar scan is coming out good, and the EF part can be calculated by echo, then I still do the scan. So it is variable, but most of the devices are compatible and can be done.
No, there are patients who are having the pacemakers, which were, especially in our country, they were not compatible.
We have an abandoned lead, If the pacemaker is not a problem, sir, we can do with the pacemaker. They have to change the settings to they have to change the settings for a while so that they are not pacemaker dependent during the period of scan. And once the scan is done, then they change it back to the normal settings.
Only thing is that the few of these devices are 1.5 Tesla compatible, then 3 Tesla compatible. So these variations are there, but mostly these days the devices are MRI compatible, so that's not an issue. Vivek, you want to? Yes, sir. Yes, sir.
Dr. Ritu,
Yes, sir.
Dr. Ritu, you had again a very good lecture, but you covered from A to Z of cardiology. So tell us, we all are senior cardiologists, what is a specific indication, one or two, where a regular echo, regular X-ray, regular things cannot diagnose and CMR will diagnose, so that we can take home some good information.
Okay. So viability is the largest indication. So whether you want to revascularize the patient or whether you want to give the patient a medical management, that is the largest indication. The second is hypertrophic heart when the patient has suspected apical HCM. And sometimes for hypertrophic heart, you do not know now what is the differential. So it's amyloid, sarcoid, it's apical HCM, then we do them. And then our EP people are the ones who send us with the rhythm. When the patient has an irregular heart rate, then MR will differentiate whether it is myocarditis, sarcoid or ARBD. These I think are the pretty much largest group.
See, the moment you say viability,
Yes.
interventional cardiologists are very, very keen to do a stent or angioplasty then and then fast.
Yes.
Sending a patient for CMR, it will take 7 days and getting the report. By the time the patient will be taken by some other cardiologist.
So
So that is the situation, you must understand. The practical situations of the life.
No, we have in-house MRI, we get the report on same day.
No chance.
Next day we intervene.
But I think more important question is still majority of people believe viability based on the PET. How can we change it to the MRI? I think that's the key.
That's the question.
That's the big question. Because they all believe it's the PET viability. CMR still has not come up in in America, it is not PET, it's CMR. But in India, everywhere it is a PET for the viability.
What I want to recommend, see, these kind of good lectures should be kept on day 2 or day 1. You know, instead of giving day 3.
No, it was on day 1 only because we were running late, that's why.
What I'm saying,
Day 1.
see, I realized, see the hall. Yesterday the hall was jam-packed, people were standing. So these are... First day also got jam-packed. So these kind of, this is my suggestion.
Thank you, thank you.
So in our hospital, cardiac viability is done by cardiac MRI.
Next year, sir.
No, sir. I'm saying about
Vivek,
the viability assessment. In our hospital, we prefer this cardiac MRI as a first choice for the viability assessment. And we are doing good numbers and we are getting good reports. And about the patient, you can't hold the patient. If you say that patient has presented late and there is a myocardial thinning and you have to wait for 7 to 10 days time for the proper assessment of the cardiac MRI, assessment of viability, they wait for, because they know that unnecessary putting a stent is not going to benefit unless you demonstrate the viability. At times it can harm. It can result in a myocardial rupture or delayed revasc lead to their own adverse effect like MR.
Your hospital has developed a reputation. Think of tier 2 and tier 3 cities where government 5 or 6 cath labs. So there the people would not wait for 5 hours. It is wrong. That's why I said this kind of lecture should be repeated for.
So all late presenter, we wait for 10 to 15 days and then viability assessment, then revasc.
Thank you very much. Thanks a lot.
Can I ask a question?
We'll call Dr. Sanjeev Sharma for his next lecture. Metal-free PCI and all approach.
Sanjeev.
Quickly about the metal-free PCI. This concept is gaining momentum in India. Hopefully it will get into the Europe and America also very soon. India has largest burden of CAD as compared to the other nations. We have 3 to 4 times higher than the US, 20 times higher than the Japan. And there is a tectonic shift we have seen last 3 decades. There is a more and more number of patients less than 50 years coming to us. Like in 90s, it was 12 to 16%. Now almost 50% of patients are less than 50 years of age. So the highest population CAD with the youngest population for the other CAD. And this is how the diabetes is increasing in big proportion in India. So that we can expect thinner vessels, long diffuse disease, in which routine stents are not possible. So we have other options like DCB, and at times for the proximal side, we can use a drug, your bioresorbable scaffold. And population is aging, so we have more and more patients coming with a high risk for the bleed. And for those scenario also, you can use DCB so that we can avoid DAPT for the longer duration. So effect with the metallic DS, this is the first generation of DS. We have seen the permanent polymer and resulting in the eosinophilic infiltrates, and there's ongoing inflammation and patient coming with a late stent thrombosis. So this is a big drawback of the first generation and second generation DS, delayed healing, positive remodeling, and coming the patient with a late stent thrombosis and with neoatherosclerosis. So we need to overcome that. And this is, you can clearly see the data from the previous generation stents. In the BMS, event rate was a little high, and subsequently with the first generation DS, and now the event rate is reduced to the less than 5 to 7%, but still we need to have something for specific situations. So we move forward. Now in India, we have two options, bioresorbable scaffold, which is a dissolving stent, and other one is a DCB or drug-coated balloon. Both of these options are available, and we have been using it and in quite a good number of patients, especially selected number of patients. This is a resorbable scaffold for the Merrill Life Sciences. It's indigenous, and we have been using for last more than 3 years, and the result has been comparable in terms of the event rate, but advantages, it get dissolved and become part of the body in next 2 to 3 years. It has got a hybrid design, closed cell on the both sides, open cell on the in between, and there is a good scaffolding, there is a good radial strength. And the stud thickness is 100 micron. This is the how they have improvised over the previous generation BVS by the Abbott. The stud thickness was 150 micron. Here it's just 100 micron. So it gives radial strength with a less stud thickness. And most of these cases we have done under imaging guidance. So we ensure that it's well deployed, and that is the bottom line for achieving a good result in the long term. So bioresorbable scaffold has overcome the drawbacks what we had the metallic DS in terms of the permanent implant, permanent polymer, and all those issues. And it provides a good scaffolding when it's really needed. In the initially few months or initial years, we need a scaffolding. Subsequently, it dissolves and get part of the body, and you have a native vessel available as a normal vasomotion. And the next option is a drug-coated balloon, specifically for some small vessels, distal disease, or side branch. So DEB is a semi-compliant balloon coated with an anti-proliferative drug, which is released homogeneously into the vessel wall during the balloon inflation. We have to keep it for 40 seconds, and the drug gets absorbed into the endothelium cells, and it prevents the smooth cell proliferation and also retards the neoatherosclerosis. Paclitaxel has been the main drug of choice to begin with. In America, this is available with the agent, paclitaxel corticosteroid. In India, we have both, and we do have a sirolimus lutein by the name of Magic Touch, and also by the name of Mosaic. And both these drugs are lipophilic and gets absorbed in the cells and prevents the smooth cell proliferation and neointimal hyperplasia. And advantage of the DCB is no permanent implant, targeted drug delivery, rapid drug transfer, acute procedural success, optimized crossability and delivery because of the balloon quality, and there is a positive remodeling, and it preserves the vasomotion, shorter DAPT. So selected indication for DCB is instant restenosis, small vessel de novo disease, large vessel when the stent size is not available, bifurcation lesion when you put a stent for the main vessel and a DCB for the side branch, and the patient who are at high risk for the bleed. In whom you want to avoid DAPT, you can use a DCB, especially a patient going for the surgery in the next 2 to 3 months' time. And the limitations are sometimes for the pre-dilatation you have acute vessel closure because of major dissection, you have to put a stent, and otherwise it's fairly suitable for the most of the cases. So this is the algorithm which tells us when to use DCB, when to use BRS and DS. If you pre-dilate the vessel and it is opened up nicely, and there is a type A or type B dissection with residual stenosis of less than 30%. These are the patients suitable for the DCB. But if you have major dissection, like C and F, and have a flow limitation, but the residual stenosis is less than 20%, you can go for the BRS. But with major dissection, you have a resolution which is more than 30%, then better you put a DS. This is the algorithm which tells us, and this use is being practiced in India, and also some of the European countries are picking up very fast in terms of DCB use. There are a few cases. This case underwent PCI, multivessel, left ventricle LED, and circumflex RCA, presented to us with a significant angina and a tight ostial ISR, 90-95%. LM to LED stent is patent. There is a plaque shift in the circumflex, but the main culprit was the RCA ostium. So we wired the RCA, dilated with the balloon, and subsequently with a cutting balloon of 4 to 6 millimeter and the osteoproximal segment, cutting all the fibrosis. And we saw the job very well done with the cutting balloon, and there is nothing inside, very well opened up the ostium. Then we put a 4 into 20 DCB, and we kept it for 40 seconds. Here we kept for at least 60 to 90 seconds at the site of stenosis, and the result is quite good, and I was confirmed, angiographic picture is good, patient is doing well for more than 6 months now. Second patient is again diabetic and hypertensive, and this patient presented with a recent ACS. Proximal disease 80%, distal close to apex is 80%, and the circumflex distal OM is 80%. So the distal vessel for the DCB and the proximal for the metallic DS. This is what we did. Circumflex stented, and this is circumflex, and the DCB, this is a 2 into 20 millimeter DCB. So in 2 millimeter, if you put a stent, there is definitely going to have ISR. So these are the patients, small vessel, distal disease, ideally suitable for DCB. So DCB 2 to 20 for the distal vessel, and the proximal vessel stent, 3 into 28, and very well optimized, imaged with the OCT, and confirmed the good result in all the segments. Next, going for the 48 years old female who had undergone PCI in the past, left ventricle LED and circumflex with the provisional tap technique. She was doing pretty well, and now presented with the ACS with unstable angina. You can clearly see there is OM coming out of stented circumflex segment, has a tight stenosis of 90-95%. RCA is patent, left ventricle LED stent is patent, and circumflex stent is also patent. So this was the osteoproximal OM which was causing significant angina. So both vessels were wired, and this pre-dilated with a 2 millimeter balloon, and you have to prepare the bed well before putting a DCB. That's very important. You have to make the proper bed before DCB. And the 2 into 20 DCB was again put for 40 to 60 seconds, and the result is good, and this is more than 9 months of follow-up. She is doing very well. Now case to BRS, bioresorbable scaffold, which is available in India, not in US, although it's available in the Europe, I suppose. And patient 48 years old, very young guy, inferior posterior MI, thrombolized outside, failed thrombolysis, EF is 40-45%, viable RCA territory, and we did the angio, 100% occlusion, very big vessel, more than 4 millimeter, wired, thrombosuction done, and subsequently, it's very important to do a OCT imaging for the BRS. We need to assess the vessel well. We need to optimize the vessel after the BRS. That is a key point for the using BRS. So 4 into 29 millimeter BRS was deployed in the mid RCA, optimized at very high pressure with 4 into 15 ANSI balloon, and confirmed it with the OCT imaging that BRS is well deployed, well opposed. That is the key for having a good outcome in the long term. So, this is the final angiogram. The vessel is flowing very well, and this patient is more than 2 years of follow-up doing good. So very young, 26 years old male, which is very uncommon in the US. Here we see very young patient also. This patient presented with the inferior MI at outside center, underwent primary PCI to RCA, then came to us for the Revasco, the LED, which was 80% mid LED. So because he was quite very young patient, so we thought better we go for angio is not running. Can you please help me in running the angio for this patient? Escape, yeah, run it. Yeah, run. So this is the mid LED 80%, and this is 26 years old male. So he doesn't want a permanent implant inside coronary. So they might miss he went primary PCI to RCA at outside center, and we assessed the LED, which was 80%, and he underwent OCT imaging and followed by BRS for the, to minimize. Yeah. Next. So underwent pre-dilatation, and then the BRS 3.5 to 32 deployed at high pressures and optimized with the NC balloon at very high pressures, confirmed with the OCT imaging, very good result, and more than 4 years of follow-up, he's doing good. This is the end result on the right side, as he is doing good. Last case is a 73-year-old female who underwent PCI at our center for the RCA, and she presented with significant angina, 99% ISR in the mid-RCA, and the LAD had an intermediate disease. LAD 60 to 70%, there is a tight ISR, and she underwent bed preparation with the NC balloon, scoring balloon, and subsequently BRS 3 into 40 millimeter, optimized at high pressure with the NC balloon for the 2024 atmosphere, subsequently assessed with the OCT, very good images, and she's doing fine. So take-home message is metal-less PCI, metal-free PCI is preferred option in younger patients, diabetics with a diffuse disease, instant trace stenosis, distal disease, and bifurcation lesions. These are the appropriate indications for the metal-free PCI. And hybrid approach with thin stud DS or the BRS for the proximal vessel and the DCB for the distal disease is the viable option in the selected cases. And the bifurcation PCI with thin stud DS or BRS for the main vessel and DCB for the side branch is gaining momentum all across. Thank you very much.
Thank you, Dr. Sanjeev.
I finished a minute before. Thank you.
Yeah, just a short question. Like DES, we have all the data for the use of antiplatelets, like for how long we should do the single platelet, dual platelet, and what is in. What about in this situation, metal-free stents? What should be the antiplatelet regimen after the PCI? Yeah, both including the DCB and the BRS. What is your take home?
For a DCB, we can even, if required, we can stop after 3 months. If there is emergency surgery, you can do even for the 1 month after drug-coated balloon, because the healing is very fast.
No, I'm just talking about the data. Do you have the data available for all these things? Because these are new technologies going on, and ultimately we have to prevent this for the secondary prevention. What should be the antiplatelet regimen?
The data, what we have from the healing of the vessel after the plain balloon angioplasty, the healing is fast. Within 1 month, we are safe for the DCB. But for the BRS, it takes at least 2 to 3 years. At times, it takes more than 2 years.
Yeah, that's what.
So we have to continue DAPT for at least 2 years for the BRS. But for DCB, you can stop even after 1 year if there is some emergency. Thank you.
Dr. Sanjeev,
can I ask?
I mean, we had Abbott absorb earlier, which was withdrawn because of thrombotic concerns. So how is this Maris different from the absorb?
Yeah, that was a 150 micron, very thick strut. That was the issue. Number 2, it was used rampantly in all lesion subset, like calcified lesion, long diffuse disease, they were putting an overlapping scaffold, even for the side branch they were putting. So it was a rampant use without good preparation of the bed, and also the imaging was not used in majority of the cases of the BVS, early generation BVS. These days, we are very meticulous. You have to do imaging, you have to assess the lesion, and use in selected number of the patients when you have prepared the bed well, like fibrotic lesion, recent thrombotic lesion, not of the calcified diffuse disease. And once you optimize with the imaging, you have a fantastic result. We don't see any complications in the short and long term.
Sanjeev, there is a question and comment both. Metal-less PCI is very true for small vessel PCI and for BRS. But for ISR, when we are using the DCB, it is already metal, so it may not be metal-less. The question, when we are using a DCB in small vessel, if there is a dissection, whether we have to put the stent there or whether we have to do the long ballooning with the DCB. And second question to Dr. Sir, is there any experience of bifurcation with 2 DCB simultaneously?
When you go for the European Dr. Antonio Colombo series, we have seen even with a large, even type C, beyond type C, type D, type E, type F dissection, they have opened up the DCB and left it as alone. Or a long-term follow-up is quite good. Short-term follow-up, 6 months, 9 months, they have seen the diagnostic angiography. It heals up. So here in India, we just do on a type A or B dissection because the mechanism of vessel opening by the balloon is the minimal dissection. So type A, B dissection, you can easily go ahead with the DCB, or if there's a major dissection, you have to put a stent, either the BRS or the metallic DS.
So key is, you prepare, you did the lesion, and lesion looks good. There is not beyond A or B dissection, you think you can live with it, then only you use the drug-coated balloon. But if you think the lesion is not good, don't put a drug coated, put our DES. Very simple. Because there is some studies have shown, you did a DCB, now your dissection and you still put a stent. Restenosis rate is very high. Those people, because now you got a double drug. Coming back to the point of even for ISR, there's still the class 1 indication for DS, ISR is another DS, not the DCB yet. Because few trials have just shown, but guidelines have not changed yet that for DCB or for DES, ISR, first treatment still is the another DES. But yes, some agent trial and those have shown, but will take some time. Now the last question is bifurcation, double DCB. I had no idea. Because we just started having it and it's not available for that purpose. But particularly latest data which are going with a large vessel, I definitely will be away from that.
Sir,
the 2 DCBs, no.
Sir, last Saturday, even Friday, we did 2 DCB simultaneously in ISR, LCX and LAD. So we search out in literature, hardly any papers we got it. Yeah. So that's why I ask your experience about this.
It's not a common situation. You always like to go with a stent for the main vessel and DCB for the side branch. This is a standard practice, it is safe also. You can't leave a main vessel, proximal LAD, proximal circumflex just for the DCB. As of now, in times to come, we might be having a data because the Italians are very, they're aggressive in terms of the DCB. I've seen a very bad dissection cases. They put a DCB for 40 seconds and they leave it on a medical follow-up. And they are quite okay with that.
True, but I'm asking for ISR, 2 ISR.
ISR, DCB. It's going to be, what sir said there, whatever comes as a new therapy, it takes time to be the class 1 indication. But definitely in times to come, it should come up the class 1 indication along with that. Yes. Thank you.
But I think, Dr. GL, first you have to look for the mechanism of the ISR. If it is a neothoracic or what is the mechanism, then only I think you should go ahead. Whether you need cutting balloon, you need a DCB or not.
No, but also problem is the agent trial. The agent trial was DCB against balloon angioplasty.
Yeah.
It was not against DES. So that's where the trouble is. So we still don't have the correct answer what it should be.
It's a fibrotic proliferation. We did the cutting and then DCB for bifurcation, 2 by 1.
So I'll request Dr. Samin Sharma for the next talk, top 10 practice-changing trials in cardiology in 2024. Dr. Samin Sharma.
So what I have done is I have borrowed my 5 minutes from the teaching case. So make it 25. So I go through this latest of the top 10. Which will be all 2024. There will be no reference from 23. And I always start this top 10 talk, which I have been giving since 1998. I started this word of the top 10 advances or trials of interventional cardiology, paying tribute to Andreas Grundtvig with the first PCI done on August 16, 77 as the father of angioplasty, and you see many years remain good. So his dream was the catheter-based percutaneous treatment of vascular disease in alert and awake patient. This is what we all learn. Every live case is being done, basically started by him. See one, do one, teach one. And then what I added is that with utmost safety, appropriateness and ambulatory. Appropriate means, yeah, there is a blockage. Should it be done? That is where the appropriate criteria comes. And of course, many of them now done at outpatient. Why? Because we are confident that there will be no event on those patients. Okay, so these are the one which we have changed our practice for 2024. It started with the first one using the mechanical circulatory support in cardiogenic shock. So basically, it is a danger shock trial and follow-up of the ECLS shock. What was the ECLS shock? These are 3-4 devices which you use balloon pump, Impella and CardioHelp, which is the ECMO, which I would say the most of the the advanced cath lab should carry, because that interventions can rapidly put. And ECLS shock trial with a 1-year follow-up was basically showed that you see the 30-day and 1 year that patients with a cardiogenic shock MI causing cardiogenic shock, no difference by using ECMO. So clear. Now you say, well, maybe some other individual endpoints may be better. But if you see all of them, whether neurological status, the recurrent myocardial infarction, repeat revascularization, rehospitalization, no different in ECMO versus standard of therapy. So ECMO, cardiogenic shock, no role, large number of patients. Then you say, well, many times what happened, it's not only the the quantity, it's the quality of life. Maybe patients will do better in terms of mobility and so on. Answer is no. Actually, more ECMO patients remain in the hospital compared to the control group. So overall, ECMO, shock, cardiogenic shock, no good. So well, we needed something to be positive. Interventionists keep trying that till we come back with a positive device, and now we came with using Impella, which is the danger shock. It started with the Denmark, then got the Germany. Took 10 years to complete. Of the 360 patients, which is the Impella against standard of care cardiogenic shock. Of course, a lot of exclusion, and basically showed that very early benefit. Right from 30 days until 6 months, curves continue to separate in favor of Impella, particularly 13% reduction in mortality in the Impella group, and of course other endpoints shown here, 58 going down to 45.8. So 13% lower mortality. But just to say, even in this day and age, our mortality is about 50% for cardiogenic shock. Now, another point, there is a trouble, while there is a mortality benefit, but we have few trouble, particularly limb ischemia, moderate to severe bleeding, and sepsis, because the catheter size is 14 French. So if you imagine, we have a smaller catheter, cause less vascular issues, there may be even difference of the 13% could be 20%. So now, as you know, by next year, end of next year, there will be at least 3 companies will come with a 9 French Impella device. And the one of them I'm bringing to India is with the Magenta. They already did few cases of the pre-cardiogenic shock cases in Delhi, but that will be another 9 French. We did the first case, starting the randomized trial in America. But key is that this area will continue to grow, Impella very useful, and people say, well, whether Impella cover the renal failure issues, which answer to this trial was no. The second is, which came up from our database by procedural versus spontaneous MI. We always feel that there is a difference between procedural versus spontaneous MI in terms of their differential mortality. And of course, clearly what has been shown is that one happens in the hospital, one of course outside, and what is the impact is the first time the publication from Mount Sinai database led by Roxana talked about in a large number of patients, over 11,000 of these patients, spontaneous MI 2,100, and those who have PCI, no MI in 89, and procedural MI in 10.7%. Distribution, when you take the troponin, anywhere from 1 to 5, 5 to 35 and more than 35 distribution is so. You see the very small number do have a large troponin MI, but of course the case will be whether it's a no MI or patients who have a procedural MI, spontaneous MI slightly different. Very important is the patients who have the diabetes or who have a high LDL, they do have a higher chance of spontaneous MI. But very important, first time in the literature shown that if you have procedural MI, mortality at 1 year is 2.2, with a spontaneous MI is 3 times. So clearly, remember all the trials, the ischemia trials and all have shown more spontaneous MI in the medical therapy group. So clearly, maybe you follow them longer, that spontaneous MI will translate into the mortality and so. Now, there is a difference, that is procedural versus spontaneous with a degree of troponin elevation. 1 to 5, 5 to 35 and more than 35. So clearly the spontaneous MI becomes adverse factor only when it is a large MI. You really kill the side branch, distal embolization or dissection, when those are the ones who have large MI, which occurs in less than 1% of cases, but those are the ones have a higher mortality, but not the lower part. So this is basically shown here that in the spontaneous MI, everyone is important compared to procedural MI, only the 35 times higher. So clearly the conclusion was mortality at 1 year was significantly increased after procedural MI and the spontaneous MI with troponin more than 35, but less than 35 is only in the spontaneous group. Say question is why? The explanations are, in my opinion, one, the procedural MI occurs in the hospital monitor setting. Second, procedural MI may be reflection of the diffuse atherosclerosis rather than true myocardial injury. We published back in 2004 data that patients we do a complex intervention and they have high CKMB release. But they don't have an outcome, bad outcome until it is more than 8 times the CKMB. And largely, the sum of the procedural MI may be due to high demand, type 2, not necessarily the true myocardial necrosis. Then the third one, which I know had been a quite bit discussion already, DCB use strategy, agent versus REC, cage-free, one trial. We know the ISR versus de novo benefit of the instant restenosis and short DAP, no additional metal. Agent trial which compared 2 to 1, the agent DCB against balloon angioplasty. Balloon angioplasty showed clearly the lower event rate with the DCB compared to balloon angioplasty, and that led to overall approval of the device. And most important, no thrombosis, which was the concept for the DCB, and yes, it bore out in the trial that there was no stent thrombosis because no stent was placed. So no, or device thrombosis you want to say. Overall benefit. And then second question was, we understood what the ISR. What about the native vessels? There have been some data, some sporadic small trials, Picolito and all, showing that small vessel, long-term DCB may be better. But what about overall taken together? This is the large trial from China, the cage-free. Basically, they have the different drug-coated balloon, not our classical ones. They're Chinese-made, swide paclitaxel-coated, drug-coated balloon, and the stent was used by the Firebird sirolimus eluting stent, which is the #1 stent actually in China. So concept was in a non-complex lesion, 1 or 2, lower length less than 60, non-bifurcation, no left main, can you have this strategy, drug-coated balloon? So our question was basically not the bifurcation cases, straightforward drug-coated balloon versus DES. And this is what we needed to know. And answer there come out to be that drug-coated balloon was associated with higher event rate compared to DES. So it's again almost double in terms of the primary composite endpoint, and of course TLR is higher. The individual endpoints shown here, there seems to be no clear-cut benefit of the drug-coated balloon in this whole group. Now, we also always learn what about the small vessel, and therefore this actually trial showed even that the death rate slightly in that favor of the DES. Now, small vessel versus large vessel, clearly they also saw the difference that small vessel no difference, but was not better. But in the large vessel, clearly it lost 3 times higher event rate. So message is, you want to use it for a small vessel, no penalty, but definitely not for the large vessel as shown here. So it's basically showing that this trial showed that indicate that DES should remain the preferred treatment for this patient population, patients who are coming for the coronary artery disease treatment. So this is, I think, this overall DCB consensus statement, in my opinion, should change in the sense that not all cases, probably keep it only for a small vessel and maybe ISR, because ISR guidelines still have not changed, which I'm going to share with you shortly. Then imaging trials, we know there are multiple trials of the imaging, IBUS and this. 2023, there were 5 randomized trials. In 24, there are already 4. I'm going to show only one, which was basically done in South Korea, OCUPI trial, angiography versus OCT guided intervention, large number of patients, and they took the complex cases. Acute MI, CTO, long lesion length, calcification, bifurcation, unprotected left main, ISR graft, and they followed the patient. Basically have the clear-cut criteria of the OCT optimization, and of course it takes some extra time. But what it did, OCT decreased the event rate by 40% compared to angio-guided PCI. And you can see here, the 7 versus 5. More important, that if you have optimal OCT, and this is where sub-optimization versus optimal OCT, basically which was done in about the 3/4 of patient, the event rate was even further lower. So once you're doing OCT, you do a great job, your event rate from 7% not goes down to 5, goes down to 3. So clearly optimization is very important to get the best results of using the OCT. So therefore, the conclusion was the finding indicate the existence of therapeutic benefit of OCT as an intravascular imaging technique for PCI guidance in complex lesion, which is added to many other data. So this was put in by Greg Stone, although presented last year in TCT, but they finally came out in the Lancet this year, multiple trials, as you can see here, comparing various of the imaging, but message is on the right side, that imaging improves or decreases basically the cardiac death, all components of the target lesion failure, anywhere from 20 to 50%, and most important is stent thrombosis by 50. Question is OCT versus IVUS. There is a trial done called OCT. IVUS showed no difference. In this trial, the meta-analysis, there was slightly trend towards lower TLR with the IVUS compared to OCT, but by definition would remain same, except the renal issue with the our OCT. This is actually at present in United States, 32% of the PCI are done in our ACC and CDR, 75% in the OCT, 25%, 75% IVUS, 25% OCT. At Sinai, we are now getting around 28 to 30% imaging in our cath lab. Then the plaque modification imaging trial, many trials, actually at least 6 of them this year, and I'm just going to show you 1 or 2, was comparison of the OCT guided, angiographic guided and IVUS guided in a calcific lesion, and basically the very complex trial in terms of randomization, what to do, whether OCT, IVUS and angio, whether criteria of these were all calcific lesions, and they used various techniques in terms of the rotational atherectomy and IVL, and showed basically that by using OCT versus IVUS, this is the yellow and blue, and angiography is in the gray. So overall showed that stent length, stent per subject overlap clearly with the angiography. You have a shorter stent length compared to imaging, but did it translate into a better outcome? Which is showed here, that if you see the malapposition and the stent area MSA, there was no difference, 485 with the OCT, 5 with the IVUS, angio 4.69. You say why? It's basically because, we know many of us that even with the angio, you'll get a good results. Now then, malapposition definitely, it slight different. There was slightly more malapposition in the angio guided, but p-value was not significant. But if you take the primary endpoint was the in-stent late loss. The in-stent late loss between IVUS and OCT was no different, but you compare with the OCT and angio was in favor of the OCT. So plus minus, but overall showed that the calcific lesion, you use this technique, the imaging didn't help much, because outcome, again, a small number of patients, about 500 patients, there was no difference in any of those TLF component. Yes, angiography did have slightly higher event rate, but very small with no stent thrombosis. There is another trial which is called Roller Coaster EPIC 22, comparing 3 trials, 3 devices, rotational lithotripsy and ELCA. In calcific lesion, they again have a clear-cut protocol, how to use, what to do, and so forth. And one device doesn't work, you go with the second the device, and basically sums it up that minimum stent area, that is what we are concerned about, was no difference between 3 technique, rotational, IVL or ELCA. The calcium fracture, more than one fracture definitely was seen more with IVL. And this has been suggested before that the IVL have a more calcium fracture, but if you take the rotational atherectomy against laser, RA was better than laser, and whether you go against the lithotripsy, both were kind of equal. So message basically was that while minor differences in imaging criteria, you can see more calcium fractures with the IVL, but outcome was not different, but definitely the laser was inferior in this calcific lesion. Then the senior reader trial, invasive strategy for older MI in non-STEMI cases. Remember, there are FIRE trial showed that even in elderly patient, STEMI, PCI is complete revascularization better. What about the non-STEMI? This was trial done in the UK, 75-year-old patient, invasive versus conservative, and basically randomized the patient. Some of them, if you see that in invasive, 90% had angiogram, but PCI was done in about half of them. In the conservative, 5.6% of cases, and death and MI was not different, slight favor, but nothing. Revascularization, of course, was slightly higher, significantly higher in the patient where conservative group, but important endpoint of the death or MI was not different in this trial with the non-STEMI. So this is the non-STEMI story. 75 years of age, not the STEMI. STEMI we know. Complete revascularization is the way to go, even patients in more than 75. Non-STEMI, because many of these patients are frail. They actually have the frail criteria. And that is why angiogram was done in 90% of cases, but PCI was done only in half. Why? Because we, after angiogram, diffuse disease, elderly, many people said, you know what, leave it alone, do the medical therapy. And this is basically at 5 years of follow-up. Then this question comes up all the time, the ticagrelor or clopidogrel monotherapy versus DAPT. This is the Sydney 3 from basically the 6 trials, Global, Twilight, Stop DAPT 2, Smart Choice, TICO, and Stop DAPT 2 ACS. This is of course trial done in Europe, USA, and Asia. And all have their interruption time period, and basically 2 messages comes. One, what about ticagrelor monotherapy versus DAPT? And this was done anywhere from 1 month to 3 months stoppage. And clearly, what did it show? Primary endpoint, ischemic, no difference, bleeding, favor of the monotherapy of ticagrelor, which we learned, and that was exactly data what Roxana showed with our Twilight trial. But once you go to the clopidogrel monotherapy, you see here there's slight, again, not statistically significant, but trend, 2.9 versus 2.4. Yes, you have a lower bleeding, but in ischemic endpoint, you cannot make a point that they were identical, they were lower. They're slightly higher in the clopidogrel, and therefore, the authors concluded that ticagrelor monotherapy was non-inferior to DAPT for all-cause death, MI, or stroke, and superior for major bleeding and NACE. But clopidogrel monotherapy was similarly associated with lower bleeding, but was not non-inferior to DAPT for all-cause death, MI, or stroke, largely because of risk observed in one trial that exclusively included East Asian and so on and so forth. But key is, if you do a single therapy, it is ticagrelor compared to clopidogrel. Then the FFR trial data, some from the FAME and the FLOWER MI, there no true new data came. The FAME trial, remember, the FFR guided PCI versus CABG. CABG was superior. Of course, in the more complex cases, CABG was more superior. Low complex cases, PCI was better. But even at 3 year, benefit of the CABG persisted, although p-value become now in the death, MI, and stroke of 0.07. But overall outcome continue to be in the CABG group. So now there is another paper came out that 22, remember syntax score low is 22. 23 to 32 is intermediate, and then 33 and above is the high syntax score. So they said, why you have to go to 22? If we can go, and of course many of these patients, anatomic versus functional syntax score, reclassification. So instead of 22, what if we can go to the 24 syntax score? And this is where the whole data came, that adding this 2% extra. Why 2% extra? Because 22 and above, 22 and below, syntax score, PCI did better than CABG, which we all learned. Simple cases, you go for PCI. Complex cases, go for CABG. But then cutoff was 22. But what if you go to 24? And this, the analysis showed that maybe by adding 2 points on the syntax, you increase revascularization of about 13% or more cases, which can benefit from the PCI compared to CABG. And this is basically very detailed discussion and they said the patient with a multivessel disease without left main, PCI and CABG outcome remain comparable up to a syntax score value in the mid rather than low 20s. So no longer 22, so 24, which allows the identification of greater proportion of patients in whom PCI may be a reasonable alternative to CABG. I think this was a good conclusion, and of course all interventions will like it. Now then, remember the FLOWER MI study was, the FFR guided PCI at 1 year was no difference. They showed the data now at 3 year, FFR versus angiography guided intervention. And if you see the death MI, unplanned revascularization at 3 year, exactly identical, no difference, FFR guided complete revascularization versus angiography guided, and the individual endpoints are shown here. Actually, if you think about recurrent ischemia was higher in the FFR guided PCI or trended towards to be higher compared to angio guided PCI. So FFR guided did not give any advantage. The 2 trials, FLOWER MI and FAME MI, both of them put together can say that if you decide to do an piece of complete revascularization in acute MI setting, angiographically 70% lesion, you go with a PCI, you don't need to do a functional study on those cases. Then guidelines of the European Society, I think this is very important for management of the chronic coronary syndrome, which we used to call stable ischemic heart disease or stable angina. Lot of emphasis on the mechanism of the MI, not only epicardium, lot of emphasis on the microvasculature. Many times we do a revascularize the patient with a CABG and PCI, the patient still have symptoms. Many of patients don't have epicardial disease, continues to come back with the symptoms. So therefore, microvascular assessment and treatment for that has been the part, and the most important being is the CCTA. Is a class 1 recommendation when you think likely of the CAD. No longer stress test, no longer echocardiography, and so forth. And they have, particularly in some cases which are high risk, directly go for angiogram. Don't waste time doing the stress test, CTA, patient has a high risk feature, direct angiography is the class 1 indication, so clearly high risk patients directly go for angiogram compared to, but CTA has become class 1, which I have been using CTA for last 25 years as a class 1 screening test. I would say preferred screening test in my practice, and we know that gives the best benefit. Then heart team discussion, of course, one of the important came out is that patient with the OCT and IVUS, we all know, imaging has become, particularly in the complex cases of the left main, bifurcation, long lesions, and so forth. And lastly, important is that some cases of left main has become class 1, low syntax score. Left main has become class 1 indication based on this data. And of course, the duration of antiplatelet therapy, which have been shown quite a bit, 1 month, 3 months based on the ischemic and bleeding risk have been emphasized. Another thing people always ask, if I want to do exercise, what should be? They actually have clear-cut aerobic physical activity of 150 to 300 minutes per week, or moderate intensity, or basically means that 30 minutes. 30 minutes exercise every day. Everybody should do. And that I have been advertising or promoting that, but even including myself, that has to be done every day, all 5 to 7 days. Then some recommendation for revascularization failure, DES is recommended over drug-coated balloon for class 1, which I said earlier, still remain. And then of course the LIMA and some cases, the ANOCA and INOCA, and that is the patient who have management of the normal coronary arteries, that you do basically assessment of the microvasculature. And then adherence to therapy, lot of additional factors which we do not pay attention. Now, the most important, I know very controversial, preventive PCI for vulnerable plaque, PREVENT in my opinion still remain the top trial of the 2024 because it was on a concept in the October 24% 2.2 hazard ratio. So therefore, there is some concept which has been brewing quite a bit, that what if the vulnerable plaque, if you can have a very low complication of coronary intervention, that can you benefit those patients, because they are going to have high event rate, but they are physiologically negative. I know that Jagat had quite a bit show yesterday. I didn't want to say on any point on that, but this is basically how do you define the vulnerable plaque, MLA less than 4, plaque burden more than 70, TICFA, lipid-rich plaque or nears, and these are the 800 patients randomized, what basically was very strict control. You cannot say that because in these cases they did not follow the aggressive lipid, yeah, they could have done a little better, but they did a terrific job. Everyone was less than 70, may not be 55, but less than 70 LDL score, and basically the angina score was not different, and event rate was, as you probably know, the 9.4 went down to 6.5 with the primary endpoint, and the other question always comes, that we do not want to cause any harm. By doing the PCI, did we do any harm to these patients? These are the primary endpoint, and that is in the red bar. We say that, yes, it's a concept we are trying to evaluate. Always, even during evaluation, we do not want to cause any harm. But did we do any harm by anything? The p-value, slightly bleeding, 1.8 to 1.4, others stroke, you take it. No difference, nowhere. The red bar is higher than the blue bar. So yes, PCI was done, may not be indicated because it was a concept, but it basically did not cause any harm, whether it's a 800, the cat ate the 800 mice and compared to a 30, that doesn't matter. Did not cause any harm. Yeah, there were 39 stents on this side, 800 stents on this side. You may have benefited, but definitely was no harm done, and these are the individual graphs in this trial, and actually BVS, they start with the BVS, with the cobalt chromium, our Zion stent was even better. So lastly, I'm going to just summarize that given the PREVENT trial is the first large trial to show the potential effect of focal treatment of vulnerable plaque. These findings support consideration to expand indications for PCI to include non-flow limiting high-risk vulnerable plaque. So I think this was a very bold statement. I'm not supportive of it because we don't change our practice based on one trial. Now there are 3 trials are ongoing at present. Combined intervene trial in chronic coronary syndrome with the same concept. Then interlima trial in patient with acute coronary syndrome, same based on the vulnerable plaque, and the FAVOR 5 AMI trial, multivessel CAD. All have their criteria of the different of the vulnerable plaque. Now if 1 or 2 of these trials become positive in 1 or 2 years, then you can make it a point that your complication is less than 1% of the PCI. And that yes, by putting a PCI in these high-risk patients may benefit. So let me sum it up now. So all these 10, so just a central illustration, as you know that most of the journals now want you to summarize the entire article in one figure. So let's sum it up. ECMO in cardiogenic shock, ROTA in ISR, although I didn't show the data on that, drug-coated balloon in large native vessel, 2 thumbs down, no benefit. Second, or maybe even a little harm, FFR-guided PCI in multi-vessel STEMI, and then invasive strategy in old STEMI, non-STEMI, and laser in calcific lesion, 1 thumb down. Then cabbage over FFR-guided PCI, FAME, increased mortality with spontaneous MI, our data, 1 thumb up. Impala in cardiogenic shock, IVL or ROTA in calcific lesion, ticagrelor versus clopidogrel alone over DAPT, and 2024 European guidelines for chronic coronary disease, 2 thumbs up. Then drug-coated balloon in ISR, imaging, OCT or IVUS in complex lesion, and the plaque modification guided PCI, 3 thumbs up. Now, I know that I did make the 4 thumbs in my earlier presentation this year because we had 2 positive trials of the last year, Orbita 2 and the PREVENT. So because of a lot of controversy, then I said, I would cut down not a 4 thumb, but I made a 3.5 thumbs. The PCI for vulnerable plaque versus medical therapy. I think this is one of the trials which really showed us positive for us to become better interventionalists and improve survival. Thank you very much. Yes.
So, Dr. Sharma, I never like to disagree with you, but with the PREVENT trial, I have to really make sure that everyone understands the issues here with PREVENT. This is an open label trial. All the patients knew what was the trial. They were told, you have a high-risk plaque, we're sending you home either with nothing or an angioplasty where we put a stent. The only difference that drives that endpoint is hospitalization for progressive angina or unstable angina, very little, no change in MI, no change in death, and for revascularization. Both of those are biased in an open label trial like that. Imagine you tell your patient, we found a very high risk plaque and we're going to do nothing. We're just going to give you medications. Or I put a stent and we opened it up and it's great. That patient will have a bias of saying, I'm having chest pain and comes in. So this, to me, this trial is so woefully biased. And by the way, when have you seen event rates with a Zion stent in a thing like that is under 1%, 2%, overall MACE rates? So in my mind, to say that, look, this was the best way and angioplasty had no harm, we have no idea. And it's only a small number of patients after all. So please take that with a caution. I'm really glad you didn't go with 4 thumbs. In fact, I would be flat with PREVENT. I have very strong feelings about this. And I have to make sure that I voice those opinions. So with all due respect.
Believe me, this is not the first time I have this controversy. Look at this trial, this slide. Now imagine this number death. You make these patients 2,000. What will happen? Death will be lower. Whether you are told or not, you got a stent or not, doesn't matter. You live longer. by getting the stent. What's the harm? Open label or closed label? Look at the myocardial infarction. How much we do, how we change the trial of the streptokinase versus the TPA. How the trial of the PCI, the PAMI versus the thrombolytic, by 1% difference in mortality. Why? Because there were 10,000 patients. So just to say that if the open label or any concept you take it, we understand that the primary endpoint is driven with the revascularization, but look at the two things only, death and MI. You multiply these cases at 10,000, 5 times, they become significant
You don't know that
positive.
it's going to be like that, Dr. Sharma. We don't know that that's what it would be. That's what a trial is about.
Understood.
If you go from 800 to 8,000, this could be completely different. We don't know. We only have 800. It doesn't mean that just because you add 7,200 more patients, that it's going to follow the exact same trends. You're underpowered for those endpoints of death and MI at the moment, especially spontaneous MI. You need larger definitive trials to say you should be able to be doing this. Of course, this was a very interesting, why do you think this is not in the New England Journal of Medicine? It's exactly for this reason of a very, very important biased endpoint, which we already know could happen in an open label trial like this. That's
But
what I
as you
would
say that Lancet has a higher impact factor now, 96.8, and NEJM is 92. Actually, last year in the post-COVID, Lancet was 180, NEJM was 160. So Lancet impact factor kind of going up than NEJM. So not to say that it didn't come out, NEJM is the region, that is not a great trial. No. Because with impact factor, we go by the impact factor, and Lancet and NEJM are tied. Some people are two here and there, but the post-COVID, Lancet actually was 30 points above NEJM in terms of impact factor, just to say. But coming back to the point, I know this, just want to make sure everybody knows it, and I'm not in favor of it, because I barely can do my own 1800 PCIs. If you start doing the preventable PCI, I'll be doing 5,000. I probably will never go home and will stay in the hospital. But point is, this is just to say, it was not that they came out of the hat and let's start doing the preventable. This has been spoken by interventional cardiology, Patrick Soraya, 20 years ago. And there was a basis of the OCT, the FFR trial, that yes, you leave those cases alone, and now you say, well, maybe the LDL was different. In the patient with a medical therapy group, LDL was 75 and other group was 55. No, that was not the answer. So just to say that, yes, very provocative, but to say anybody who try to bash it down, and I told George, Jagat Narula, I presented that in June in my friend, was any harm. So let's put this way. The concept is there, but this concept still need to be proven by the 3 randomized trials which I showed you, already ongoing. But by doing this, there was no harm done to the patients. Thank you very much.
Sir, regarding CCS in 2024 ESC, you are stressing about CTCA. I know you are practicing CTCA in Europe and here also. But as you said in your lecture also, without doing 2D echo, without doing stress test, how you can convince a patient for CTCA?
That's a very good point. So I think very good. So you require probably echo to convince them.
Probably TMT, treadmill test.
Well, no, not necessarily TMT, echo. Do echo and CTA. That's what I do.
In echo, how can we prove the ischemia, provocable ischemia?
No, but echo is what patients say, you know what, they did a small test, now doing more advanced test. But I'm just saying the guidelines are there. So the key is that now CTA and everywhere that you want to screen for coronary artery disease, your test is the CTA. Now, you want to screen for LV dysfunction, for heart failure, for anything, of course you need to do echo and other things. But key is the TMT and all that, like secondary, is the CTA above all of that.
Can I add something, sir? Early atherosclerosis, for example, 40-50% lumen occlusion will not be picked up by any stress test. So this is one way I convince my patient to get it at early, particularly those who have family history of heart disease. And sir, vulnerable plaque is basically a problem of general population, and I think more and more non-invasive tests we need to have for vulnerable plaques to save lives rather than OCT probably. But yes, somebody is already there in the cath lab and we can identify in vulnerable plaque and decide a treatment strategy.
We cannot pick the vulnerable plaque in CTCA.
No, we can. We can. Dr. Jagat Narula talked about this. Dr. Ritu must be here to speak about that.
CTCA, yes. How many patients we can convince directly for CTCA here in Jaipur?
I do. I say early atherosclerosis will be picked up only by one test.
Yeah.
Not by any stress test. Yes.
So
all my friends who are of my age, I have done CTCA for everyone.
I got 4 times. You start at age of 40, then you do a 10, 5 and you know.
See, sir, take it like that. If in CTCA there is a borderline plaques, so then you have to go for invasive.
No.
Then what you are going to do?
Now you can do your stress test.
Reverse.
Now you can do stress test, reverse. That's the key.
Agree completely.
Yeah. And then more aggressive treatment of that.
Yes, high dose statin at least.
That is the treatment. For investigations, sir is telling reverse, you have to come for stress.
Reverse. Because many times you don't need any. So other question is, CTA is so much improving. I know that Narula showed that also, that at present, right now we do FFR. So that lesion, 30-40%.
It is again invasive,
FFR
sir.
negative, you do nothing. No stress test.
Non-invasive
Anyway, we have to do the angio.
Non-invasive FFR.
CTFFR. And then there is a new program about the plaque characteristics which is coming with the CTA. You know, they have positive remodeling, all those the things. They will give you that this plaque, 30% high risk plaque or low risk plaque.
Yes.
So all these things are happening and they are happening now, even at Sinai. They started, we just got that program. FFR we are doing for last 5 years, but now we added this new part.
Another problem here in Jaipur, in India, this CTCA is not reimbursed by the companies. TPAs, you are getting the TPA there, that is reimbursement you are getting, but here we are not getting the reimbursement.
Yeah, that's the issue, and it is more expensive than conventional angio. That's the issue in India, yes, really.
Your question, yeah.
So what is the status of only calcium scoring? If we do the calcium scoring without angiography, what is your...
No, I think that may lead you to going in one direction, calcium score 0, but I know personally many patients who have 0 calcium and they have this the large bulky plaque and they went to the cath lab FFR positive or the CT FFR positive with a 0 calcium. So calcium is a marker, but I think it is kind of a more primitive. The patient came to see you in the office and you just felt the pulse. That's your calcium scoring. ECG, further on, that's your more advanced testing.
Just to add some few comments about CTCA. As you already said, there are 4-5 high-risk features. So Dr. Sharma should know, if you have high-risk features, you can put the patient on statin, not necessarily take him for angio. Number 2, CTCA has proved better than any cardiac biomarker. Number 3, if you have a functional stenosis, you can do a CT FFR, except microvascular dysfunction. If you have microvascular dysfunction, then CT-FFR is misleading. So we have a good role of CTCA for identifying patient who can be started on early statin therapy, patient who want to undergo angio, but CTCA rules them out, and the fact there is no functional stenosis, then they can come out of, they need not go to the cath lab. And as far as Dr. Sharma says that it's hard to convince, I have seen a lot of patients with non-anginal pain chest lying on the cath lab. So there's no point, you can convince patient for anything.
Exactly. Sir, but still CTCA, when we are taking patient for for valvular surgeries, CTCA surgeons is not accepting if it is normal then.
I think this discussion, deserved a jam-packed hall which we don't have today. So we move ahead now. Please.
There is a CT fast trial where the surgeons have taken patients depending only on CT angio. No invasive angio was done. There's a large trial, CT fast track.
Thank you to all the speakers. Panelists, I would request you all to please stay with us. I would request all the panelists to please be with us for the next session. And additionally, I would like to request Dr. Samin Sharma sir, Dr. Sanjeev Sharma sir, and Dr. Kapil Bhargava sir to please join us for the next one.
So I'll request for the next talk, Dr. George Dangas, and he'll be delivering the lecture on renal denervation, emerging therapy for the hypertension management. Yeah, so.
All right, great. Thank you very much for asking me to give this talk about a new subject. And can we have the slides of this talk, please? This is from yesterday. I already gave this talk.
I thought you gave it already.
Yeah, this I gave already. Please give a... No problem. We can load again if there's some situation. No? No? Second one. That's it. Open it. Launch. All good. Perfect. All good. Excellent. Oh, we got it. So definitely a new topic. So new that the slides couldn't get figured out also. That's good. So let's talk a little bit about what's a concept, first of all, as Dr. Sharma said. What's a concept of a new therapy? The concept here is that hypertension, although something seems much more pedestrian and maybe not as complex as left main PCI bifurcation, stenting, SGLT2 inhibitor, GLP-1 agents and all that, it has a tremendously more direct impact to all-cause mortality and stroke-related mortality, even at the minimum decrease, if this is achieved on a population basis. Why? Because there are just so many people who have high blood pressure, and there are so many things in the body that blood pressure, systolic blood pressure particularly, affects, such as stroke, kidney disease, etc., etc. Now, what about the kidneys and the blood pressure and the nerves? There is a bidirectional connection between the efferent sympathetic signals from brain that have something to do with the renal angiotensin aldosterone system, and at the same time the stress kidney signal back the central nervous system. There is a lot of sympathetic innervation in the abdomen that goes through the way the arteries branch out of the aorta. That is the concept. That's where the sympathetic nerves are. So they're kind of like on top of the arteries. And that's where you can find them. And we know from traditional work that the thermostat for blood pressure in the body is the kidney. So the question is, and you can see now the cross-section of the artery of the kidney. The vessel lumen is at the top left here corner of this wall. This is just a cross-section, and on top of the adventitia are the renal nerves. And because over the last year we are dealing with many aspects on this globe that have to do with war, let's just imagine that we're launching some missiles from the vessel lumen and we just want to hit the renal nerves, but we don't really want to destroy anything around media or adventitia. And that's why we use some kind of energy, this type of energy that is going to potentiate in this, but in a depth of 3 to 5 millimeter and not burn the entire vessel wall. That is very important. So where have we been with this approach to essentially buzz the renal sympathetic nerves in order to reduce high blood pressure? We started, there was a Simplicity Hypertension 1 trial, the first in human proof of concept study that make big headlines. And that obviously followed a lot of animal experiments indicating that it goes through to actually damage the nerves at 3 to 5 millimeter depth of the vessel lumen without necrosing the vessel wall. That was the basic safety concept we had to establish. And along the line, we found out that the simplistic hypertension 3 in the larger trial, when this concept was out to many centers, things didn't work out very well, perhaps primarily because we weren't so clear of how to screen the patients better, optimally, for the study. Nonetheless, we're going to see later that we used the lessons from simplicity to establish that there was no harm in any way of this concept that I keep saying that we are damaging something outside the renal artery vessel wall without damaging the vessel wall and without creating any renal failure risks along the line. These are two very important safety features. And then we regrouped, so to speak, and went back and redesigned studies that are more specific, more difficult to do because they had to be a higher level of screening, spiral hypertension, on-med and off-med. That was the other new principle, that instead of building up for resistant hypertension, people who are on 3 or 4 drugs, perhaps give a chance to people who don't tolerate any medication. And perhaps it can sound strange to an audience of interventional cardiologists that these people exist, but if we are to give this lecture to an internal medicine group, they have many of those patients that just can't control them. And as well, newer devices came that don't exactly have radio frequency, they have acoustic energy, and we're going to go through some of those studies as well. And these are the 3 types of energies, the multi-electrode radio frequency ablation. The catheter has a configuration, a circular configuration, is called the spiral for this reason, and has different electrodes at different sides so that just by hugging the vessel wall, you can actually launch radio frequency energy from all aspects and all quarters of the vessel wall. Then we have the balloon-based ultrasonic energy. I think that is the easiest to understand in this audience. And also we start developing some other infusion-based devices that are not exactly ready for prime time yet, but are under evaluation for inclusion or alcohol or perhaps infusion also some chemotherapeutic agents, actually bleomycin, etc. This is obviously, the last part is possible, but is under investigation. So this is how the catheter looks, just to talk a little bit about it and give some angiograms in order to jazz up this audience. You can see, first of all, the cross-section of the catheter here, how circular it is, right next to the catheter on the left, the top left. And you can see that the electrodes have a configuration covering each quarter of the vessel wall with good contact. And you have a lot of buttons and sensors near the operating table that indicate to you that the apposition is good and that the impedance is optimal, and then you just push the different buttons to select which one of the electrodes you want to activate, and you just burn for a few seconds. And then you move on. I'll have a case in the end about that. The first study that finished was actually the off-med, much to the surprise of everybody, my surprise as well, again showing that there are a lot of patients out there off meds, can't tolerate meds, and qualified, and after a painstaking visit number 2, as we call, after they we have to also demonstrate a good compliance through pill counts and other things, because that was another aspect of that in the other aspect. Obviously, in this sham control study of meds, you didn't have to do that. But that was a visit 2, had to at least show that the patients were in good compliance with a low salt diet. They would actually show up and they would be a reliable patient. And they also were able to complete the 24-hour ambulatory blood pressure monitoring. So after that, they had a procedure, either sham or renal denervation. They were followed up, and Then they had a pre-specified analysis of 80 patients at 3 months, and then they continued at 12 to 36 months with drug titration and follow-up, as well as they had an optional unblinding, a crossover to radiation, to denervation at 1 year. The results were staggering. You can see the reductions with the renal denervation group. The sham control didn't have much reduction. There was a minimal reduction, about 2.5 millimeters of mercury in the office blood pressure, but in every category, systolic and diastolic, ambulatory blood pressure and office blood pressure, was a tremendous difference at 3 months with the denervation. The ONMED was a similar one, except that was an even more complex visit too, because you had to measure the counts of the pills and to make sure even the levels of the pills were measured, of the medications were measured at some time, because one of the major criticisms of simplicity failure was that a lot of patients with fake resistant hypertension had been enrolled. And what do I mean by that? They had blood hypertension, but they were faking the resistance by being non-compliant. So they would just keep adding medicines, and patients kept not taking medicines, and they were deemed resistant, were in reality were just non-compliant patients. So in simplicity, ONMED took care of even more measures to control the compliance and to address this visitation. Of course, everybody who made it in the study had to face us with at all and include, why do I have to take all these pills once again? I just did it a week ago or 2 weeks ago. And of course, they don't understand the broader picture that the FDA background criticism had played on that, but we didn't either. It was a very difficult study to complete, in all honesty, and ultimately it was a 2-to-1 randomized study of denervation versus control, and again had a tremendously positive results at 6 months. A small group, 80 patients, it couldn't be any bigger with this kind of very difficult clauses to meet. The office blood pressure results were just the same as the ambulatory blood pressure results. Following both of these trials, the renal denervation seemed to be abandoning the need for ambulatory blood pressure monitoring for the very simple reason that you can see here, that the results were just identical with the office blood pressure. So at this point, we're just going with the office blood pressure in the United States after the approval of renal denervation. It's not mandatory, the ambulatory blood pressure monitoring. We reserve ambulatory blood pressure monitoring for difficult cases or perhaps suspected nocturnal hypertension and all that, but nothing to do with the qualifying patients for renal denervation appropriateness. Long-term outcomes, do we have? Because I just presented you some efficacy on about 80 patients in 2 studies or so. Well, the safety is a main concern in the long term. Remember what I told you earlier, that the simplistic hypertension 3 provided us with tremendous bulk of data long term, that no harm was done to the kidneys, and that the results in the blood pressure were sustained. Yes, they were. No harm was done, and no renal artery stenosis were found in any sort of follow-up or adverse reactions. So that's great. And this has been also seconded by the Global Simplicity Registry, which included any cases, clinically driven cases that were done anywhere in the world that this device was approved, such as in Europe, as you can see, in South America, in Canada, not in the United States. Let's go now to save a little time, to go now to another system, to the second system has already also approved in the United States with the ultrasonic energy. Very similar in some ways. One can think about the IVL balloon, but of course it doesn't break any calcium here. It's a little bit different setup of the energy, but clearly damages the renal sympathetic nerves. So there was a renal denervation versus a sham procedure in this study that you see, and the results were very highly significant. That with the systolic blood pressure decreases, as you can see here. So this is another aspect that is being approved in the United States for human use. And you can see how they pans out, the follow-up in the blood pressure is pretty sustained, one can say, outcome. That was another question, not only the long-term safety, but also the sustained results over time. The answer is that they are sustained. So these have made it into some guidelines, into the ESC. American guidelines haven't been updated yet. We'll see about that. And we're clearly trying to find ways to have them become mainstream because they've already been approved for human use in the United States, both of the systems. There is no reimbursement code yet. It just came in as an inpatient possibility to do something like that, but not the outpatient code. And most of these cases are meant to be as an outpatient. But anyhow, the screening and the evaluation are working. This is based on the FDA approval. These are some aspects. Let me just show you a renal angiogram. This is a baseline angiogram we do selective after some nitro. We allow the full face to see the renogram as well. The catheter is aimed to produce radiation in 3 branches of each renal artery and before of the main renal artery trunks. Let me just go back to the previous one to show you. So we induce the catheter in 1, 2, 3 of these branches and then come back to that. So you have to kind of make a little plan of yourself, which catheter is the best one or the most difficult one to wire. You start with that one to make sure after you retrieve that, and then you can easily wire the other vessels as well, and put the catheters up here, and then go to the others, and then finish with the main trunk going back. This is pretty much what happened here. This is 1, 3, and the 3rd artery coming all the way back slowly. And you have to cover all these areas, anything that's above 3.0 in diameter as you enter. And the final angiogram you see in this picture, you can see that there's no spasm or anything involved with the procedure. Everything seems to be uneventful, so to speak. It's a 6 French arterial system via the femoral artery. Very low risk for complication. Most of these people are excellent for closure with a closed device. Anyhow, these are the 2024 guidelines for hypertension, as I told you, and my take-home message is as we wait to find new ways to incorporate those in our practice, and we wait for the US guidelines to be updated, as well as we wait for a reimbursement code to allow the outpatient procedures, and at the same time, we all gear up on how we want to create now a resistant hypertension team, because we're going to need hypertension specialists, nephrologists, and imagers of renal arteries together with us to work on figuring out how to create a program on a hospital basis and how to run this in an optimal way. Thanks so much for your attention.
Thank you for a nice lecture, Dr. George. And in fact, it is a story of perseverance and conviction on the behalf of investigators, because this therapy has seen a roller coaster ride from no benefit to benefit. So, as you said that the guidelines have excluded patients of less than 30 GFR. So don't you think this is the most, I will say, the group which will get the most benefit, because if you have GFR less than 30, they will have the most resistant hypertension and they will have the most cardiovascular event rate. Any thoughts on that?
Well, yeah, sure. I mean, what you're saying is right. The question is that we don't know if this hypertension can be modified at this advanced stage by renal denervation. That's number one. And number two, we don't know how safe this is, because this is an iodinated contrast procedure, and we may propagate some deterioration of renal function. So we have an unknown in the efficacy and a safety signal here. One can say, could dialysis patients be helped with a high blood pressure? And if that the reduction with this system, at least we don't have the safety signal there. I think that might be a study to be undertaken. Typically, dialysis patients are excluded by all the initial approval studies just because they have a high mortality regardless. and they may not make it from any other comorbidity. But that may be a way to break into this system, to break this population of the low GFR, because at least there we're not concerned about the dye injury. And if we get a signal of improved blood pressure in dialysis patients, we go from there.
Dr. George, do you have any histopathological data of comparing the radio frequency versus ultrasound guided? What is the depth of the lesion? And how do you control the lesion in the ultrasound guided system? Because radio frequency, you can control the lesion delivery, but how do you do that in the ultrasound lesion?
Yeah, no, we don't, comparisons will come. There's nothing yet there. We're just going to compare. Maybe the magnitude was a little bit bigger with one system versus another, but these studies were different and all that. I think right now we have more of a trouble how to get the program off the ground, and I think that's a more important goal at this point than the comparison between the two systems. I think any system hospital has, it's good. We're experimenting with both systems, our initiation of our program at Mount Sinai, but clearly any program, any system the hospital has, the most important is how to streamline the work between hypertension clinics, nephrology, imaging, and interventional team, and that's where we have to work on first.
And I know that technique is available now in India. So Jitendra and Sanjeev, are we using it at ESCC yet or no? I see.
We have done one case.
One case has been done, yeah. So it's available now. And actually, one of the paradox is, they say patient has to be compliant with medication. If you really think about, you want to use this in the patient who is non-compliant.
Well, that's why we use it in the off-meds.
Yeah.
And because that's why the lessons of Simplicity 3 were very many. One of them was that the extent of non-compliance was vastly underestimated before. And then we made a study, okay, let's do it in study, we don't take any medicine, let's see how they go. So clearly that. On the other hand, I have to say FDA and all the reviewers, they don't want to acknowledge that non-compliance is a way to go. And they want to, I would say, boost the adherence and the compliance. So it's a little difficult to acknowledge up front that there's a treatment for non-compliant people.
Thank you, Dr. George. So now I request Dr. Pini to take over. He'll be talking about the emerging devices for cardiac remodeling in heart failure.
Well, thank you very much, and thanks again to the conference organizers for inviting me to be here this weekend. Thanks to everyone for your very, very warm hospitality. So for the next 20 minutes or so, I'm going to talk about some emerging devices for cardiac remodeling to treat heart failure. So to start off, I think it's important to recognize that our patients with heart failure have very, very high residual risk. They're symptomatic. They face a very, very high risk of dying in spite of being treated with 4 classes of guideline-directed medical therapy. And as a result of that, we're seeing a rapid expansion of heart failure devices to meet this need to address that residual risk. So I talked a little bit on Friday about some of the devices that we're using to treat heart failure: preserved ejection fraction, intraatrial septal devices, greater splanchnic nerve ablation. Today what I want to talk about are some devices that are being applied for those patients who have heart failure with reduced ejection fraction. We've already seen the establishment of some devices. I think the best example of this is mitral valve TEER, where with patients with severe mitral regurgitation, now even with moderate mitral regurgitation, a strong signal of benefit in those patients who are already taking 4 classes of guideline-directed medical therapy. But we're also seeing now the emergence of devices that target left ventricular remodeling, and let's dive into that. So underpinning this is an understanding of the physiology of the remodeled ventricle, which bases on Laplace's law. And Laplace's law tells us that the amount of wall stress is directly related to the size of the ventricle, to the radius of the ventricle, and it's inversely related to the thickness of the wall, or thickness of the ventricle. And so as a result of that, we now recognize that reducing wall stress is a therapeutic target. something that we can mechanically manipulate in order to improve outcomes. So this was a concept that was put forward by Mickey Brenner and some colleagues at Columbia University, recognizing the fact that the medicines that we use to treat patients with heart failure and reduced ejection fraction are associated with reverse remodeling themselves. And so whether it is guideline-directed medical therapy, cardiac resynchronization therapy, or perhaps the most extreme example of reverse remodeling, what we see with left ventricular assist devices, that remodeling is indirect. What we now recognize is that we can physically remodel these ventricles with the use of devices. And again, this takes advantage of Laplace's law. This is not a new concept. The concept of remodeling has been around for many, many years. It started with our surgical colleagues in the Batista operation. And with the Batista operation, there was a recognition that if you could excise a portion of the non-contracting ventricle, make the ventricle shaped more like an ellipse rather than a sphere, that would have a benefit in treating heart failure. However, when this was more critically evaluated, the Batista operation was found not to be effective. There are other devices, the coapsis device. This was designed to try to minimize the degree of mitral regurgitation in a remodeled ventricle. But it turns out that the coapsis device actually induced reverse remodeling. Patients who received this device actually had a smaller ventricle compared to those who did not. And there's also the core cap, or the acorn device, which tried to passively prevent the ventricle from getting bigger. This also showed the ability to not only prevent ventricles from further dilating, but there was some reverse remodeling associated with it. Did not receive FDA approval in part because of concerns that if those individuals needed repeat operations, in particular coronary bypass surgery, they would not be able to get access to the coronaries because of the presence of the device. But there are other surgical devices too. There's the SAVR procedure or the DOOR procedure where you try to exclude an aneurysmal non-contractile segment of the left ventricle. And this was the idea then behind the parachute device, which was to reproduce this with a percutaneously delivered device that would sit in the apex of the ventricle and exclude that non-contracting area. And that then leads us then into where we are going nowadays, which are select treatment goals to reduce left ventricular wall stress, to minimize the invasive approach, move those surgical techniques into the cath lab where we can be doing this in a lesser invasive way, and to preserve options for future heart failure interventions. So probably the best example of this is the AccuCinch device. This is a device that is currently undergoing pivotal clinical trials. It is a device that is uniquely designed to try to reduce left ventricular wall stress by shrinking the ventricle, by pulling the left free wall closer to the septum and reducing ventricular radius. This is the way that the catheter is delivered. It is retrograde across the aortic valve. A track catheter is placed back behind the papillary muscles. Then there's a series of anchors and sliders that are asserted along a cinch cable, and when that cinch cable is tightened up, the ventricle becomes smaller. So it consists of three components. There are anchors. Typical implantation is between 12 and 15 anchors. In between those anchors is a slider, which is there to try to distribute the amount of radial force. And then a cinch line, which is a polyethylene cable that when pulled tight will distribute that force along the left ventricle. And then it is locked in place by an anchor lock. This is an example of what it looks like in a cartoon. You can see the access catheter, again, going back behind the papillary muscles, staying clear of the chordae. A delivery catheter that allows very, very efficient delivery of the anchors and evenly spaced sliders in between them, and then the cinch itself. This is what it looks like in an actual implant. On the left-hand side, you can see the anchors and the sliders have all been implanted. As you begin to pull tension on the cable, you take the slack out, and the tension goes away, and you can see the final completion at the completed cinch on the right. So here you can see those anchors and sliders are very loosely aligned, and as tension is applied onto the cinching line, they are all pulled closely, tightly together. And then you can see in this one particular example that there is an almost 10 millimeter reduction in ventricular radius as a result of the procedure. So this is what the device looks like. On the upper left-hand side is what it looks like in a cadaver, where you can see the cinch line, the anchors, and the spacers. On the upper right is what this looks like 90 days after implant in an animal model, and you can already begin to see that cinch line is becoming incorporated into the wall of the left ventricle. Here you can see the histology. There's a lot of inflammation. As a result of that inflammation along the cinch line, there is a very, very brisk fibrotic response. That fibrotic response holds that cinch line locked into the myocardium. And in fact, in some of the early implantations, it was recognized that there were fractures of the cable. However, the cable didn't go anywhere because it was held in place by that fibrotic tissue. So recently, there was the publication of the first 51 implants. This is the first in human experience with the AccuCinch device. Looking at clinical outcomes, you can see that things are essentially how you would like to see it. There are improvements in Kansas City cardiomyopathy questionnaire, so significant early and sustained improvements in quality of life, as well as improvements in 6-minute walk distance. Now, what's really interesting is to look at what happened to the ventricular volumes. Immediately after cinching, there was a reduction in the ventricle volume, as one would expect. However, when you follow this out over 12 months, you can see that there are further reductions in ventricular volumes, which means that there is a coupling first of the mechanical reduction in ventricular size, followed by an ongoing process of biological remodeling. And so this is probably best graphically shown here in a CT scan on the right-hand side of the slide. In the magenta is what the ventricle looked like immediately following cinching. And then in blue is the ventricle 12 months later, and you can see that there is ongoing LV remodeling with reductions in ventricular volumes. And this is what we think translates into clinical benefits, significant improvements in New York Heart Association functional classification without any decrement in NYHA class. And there's a signal, at least, that there was a reduction in heart failure hospitalization, comparing the period 12 months before the implantation and the 12 months following implantation. Now, I briefly showed this before. This is the BioVentrix device, the device that's not currently being used, but showed how you could take the concept of a door procedure where you want to exclude that aneurysmal non-contractile area of the ventricle and plicate the ventricle using a hybrid approach in the cath lab with a surgeon and interventional cardiologist to exclude that area of non-contracting myocardium, make the ventricle smaller in its radius, and take some of the wall stress off of the remaining areas of the ventricle. Now, the other component of Laplace's law is not just ventricular size, remember, but it's also the thickness of the wall. And we can manipulate this to say, if we can make the wall thicker, we can distribute that wall stress a little bit more and reduce wall stress. This was originally tested in Europe. This is an alginate that is implanted in an intraoperative procedure, injected directly into the myocardium to make the myocardium thicker. Stefan Anker published this paper a few years ago with the signal that this device or this approach actually was beneficial. The problem, of course, is it could only be done in the operating room. So several companies, this is DECA, a Chinese company, developed a way to deliver this alginate percutaneously in the cath lab with an injecting catheter and a microneedle that can inject it directly into the wall of the myocardium. And these data were presented last year at TCT by Dr. Scott Lim, showing that in at least this early experience of about 10 patients, that there were improvements in functional class, improvements in 6-minute walk distance, and improvements in KCCQ score. And just as we saw with the CoreCinch device, there are changes in ventricular volumes over time. There was a reduction in end-diastolic volume and a reduction in end-systolic volume, but there was a greater reduction in left ventricular end-diastolic volume. As a result of that, ejection fraction actually improved in these individuals. So in conclusion, I hope I can prove to you that there is a very, very high residual risk that our heart failure heart failure patients experience, high risk for heart failure hospitalization and ongoing symptoms. There are multiple devices now that are underway in clinical evaluation that are targeting specific pathophysiologic mechanisms, and we expect that these treatments will help benefit our patients, reducing their symptom burden and improving their survival. I think the biggest excitement that I have is with the LV remodeling devices, particularly with the AccuCinch device. They appear very, very promising in clinical trials. Thank you once again.
And excellent coverage. What are your thoughts on the cardiac contractility modulation? Why I'm inquisitive is because now the device is available in India.
Yeah.
So we want to have your thoughts on that.
Yeah, so CCM is very, very interesting, and the concept is that if you deliver a pulse during the absolute refractory period, you get increases in intracytosolic, intramyocardial calcium, and as a result of that, you get an increase in systole. It also improves diastolic function too. So in clinical trials with CCM, we can see improvements in functional capacity, improvements in peak VO2. However, in the United States, it's been very, very slow to be taken up. And I think one of the reasons for that is the commercial launch happened to coincide with COVID-19. I think the company is trying to catch up with that. In the patients who I have taken care of who have been treated with CCM, I think the greatest thing is it improves their functional capacity, improves quality of life. We don't yet have a signal that it improves survival. But again, I think heart failure patients are so symptomatic that they're looking for other ways to feel better and be more active, and I think CCM holds promise that way. Thank you.
So I'll be called for the next lecture, Dr. Roxana Mehron, and she'll be talking on say-in prediction and best management strategy.
Thank you again. So it's CIN prediction and best management strategies, and we call this now contrast-associated acute kidney injury rather than contrast-induced nephropathy. So, of course, the number of procedures increasing, but so is the complexity of our patients, both with CTA and then coming directly for coronary angiography, changing many, many ways of how the millions of procedures that are being done and the amount of contrast that each of these patients are receiving. Is it only contrast-induced? It's literally, there are several important issues to understand that it's not just about the contrast, but so many other things that are happening. These are several contrast medium-induced nephropathy studies that demonstrate a similar incidence of AKI, dialysis, and death between the people who had contrast medium versus control group. And many have questioned, is this even a thing, or is this just a creatinopathy? In other words, the creatinine goes up, but really there's nothing wrong with the kidneys. So we have to define what it is that we're looking for. It is for contrast-induced nephropathy greater than 0.5 milligrams per deciliter increase, or a baseline elevation of about 25% increase. It usually occurs between 2 to 5 days after exposure. Other factors like hypotension, medications, or atheroembolic phenomena can also precipitate AKI after contrast exposure because you're having a procedure. So it's a patient who has, other medications on board, who experiences hypotension, and catheters are going up there. And then, of course, that's why we call this contrast-associated acute kidney injury. The mechanisms are very interesting and multifactorial, and no one really knows the one single mechanism. There is a direct nephrotoxicity on the tubular epithelium, loss of tubular epithelial polarity because of the redistribution of sodium-potassium ATPase from the basolateral to the luminal surface of the tubular cells. There is a very important increase in the sodium delivery to those distal tubules that leads to renal vasoconstriction. And then, of course, there is luminal obstruction from the epithelial cell detachment. So those are the direct mechanisms that have been previously seen. The indirect mechanisms is an ischemic injury, and also, which is contrast agents can do because of the vasoconstriction, reduce glomerular blood flow, reduce oxygen delivery Of course, that gives an ischemic injury. But remember, all of these have some differences in viscosity and osmolality, and further reduction in the microcirculatory flow and changes in the blood osmolality that causes the impairment of erythrocytes and increases the risk of microvascular thrombosis. So there's a lot going on here and we just keep giving contrast. Every time you're injecting contrast, think about all these things that are happening to the kidney. The importance is very, very huge. In the nationwide United States study, the main determinants were associated comorbidities like sepsis, infection, congestive heart failure, and ACS presentations. And I think it's very important if you're going to be injecting contrast media that you should know more about it. You have to know the molecular structure, the differences between high versus low versus isoosmolar compounds. You need to understand the iodide concentration. And remember that the osmolality of a low osmolar compound is twice as much as the isoosmolar compound, so that you can understand even the low osmolar is twice as much, but in what you gain from isoosmolar compounds, you lose in viscosity. So you see that they have a higher viscosity. So important to understand viscosity, ionicity, and of course the osmolality. We don't even talk about high osmolar compounds because they're just not available, and I hope none of you are using it here in India. And of course, the guidelines, it tells you that the use of low osmolar or isoosmolar is what is recommended, class 1A. Treatment, there is no definitive treatment. There have been so many trials that have been done. Prevention is the only way to go, most important measure. And remember that this is in patients undergoing PCI procedures. Determine the risk. If they're at high risk, use low osmolar or isoosmolar contrast. Minimize your contrast volume. Stop the nephrotoxic agents. Give them isotonic sodium chloride intravenous hydration, especially if they're dehydrated, and make sure that you assess and follow the renal function. So assess the risk, minimize contrast volume, hydrate. The strategies are here. Of course, very, very important is this pre-intervention, pre-procedural intervention with intravenous hydration, statins, stopping nephrotoxic agents. The idea of device-based, we've talked about a little bit about divert, which was a system that was diverting the dye, so minimizing the dye. Renal guard, really pushing diuresis. Impella, one study, really nothing to do. In fact, we're finding more acute kidney injury in the next, as you all saw in danger shock and other things. So remember, these large bore devices with so much going on could have negative impact on the kidneys. Imaging, really important. Why? Because when you use imaging, you're minimizing how much dye you're giving. And then, of course, the other important things are coronary sinus aspiration, remote ischemic preconditioning, radial access, everything that you could do to reduce contrast media volume, and of course using the isoosmolar or low osmolar. There are 4 pillars of prevention: identifying the patient, hydrating the patient, minimizing contrast medium, and of course the only preventive treatments that have some skin in the game still are statins, questionable nitrates. Let's talk about the how do we identify patients. There are risk scores, and you see them listed here. I have 2, but they're literally the same. One is the original one that was developed, and it's in almost every EPIC, many across the country. It was published in 2004. It was one of the highest cited articles, I think over 2,500 citations for that single article. And now we just, using the Mount Sinai database, updated it to, in a Lancet publication, to the Moran 2.0 risk score. It's recommended that all patients with a class 1 recommendation are assessed for this risk. Now, whether you use the risk score or you use other things, think about CKD, hemodynamic instability, diabetes, and congestive heart failure. 4 of the most important. If they have these things, they're at high risk, and you've got to minimize the contrast media. Volume. Volume matters, of course, very important. This is the original risk score, developed in 2004, validated in multitudes of settings. Simple risk score gives you calculation and gives you what the risk of contrast-associated acute kidney injury and risk of dialysis is. And you see on the right side that these are high risk. That's why we had to redo it and give it a higher ways, because of these remarkable advances. When I first developed this risk score, it was an overall 18% rate of contrast-associated acute kidney injury. Nobody wanted to talk about it. In fact, when I would give talks on this, I would be in some corner in the TCT meeting, and that's how you make lemonade out of lemons that are given to you, to the young researchers out there. Nobody wanted to hear about acute kidney injury, and I, the only woman in the group, got the crumbs of the research, but I made lemonade, and I made this risk score out of it. And in fact, over the years, that number is now down to like 4%, and I'll tell you what's going on. And that's why we went on to this risk score using our database here at Mount Sinai that Dr. Sharma and Dr. Kinney developed in 1998, and have all of these patients in there with creatinines and follow-up and understanding what's going on. And what we did is we used this risk. We came up with the model 1, using the clinical presentation, the GFR, ejection fraction, diabetes, what's the hemoglobin, what's the blood glucose, congestive heart failure at presentation, and the age of the patient. Now, isn't this is starting to look like iterative AI, right? We could actually, again, use these risk scores to be able to imagine what could happen to the patient. And because using the second model of how much volume you give, if there is a procedural bleed, if there is slow flow and there's complex anatomy, you start to get even more deeper into understanding and more accurate into predicting contrast-induced acute kidney injury. The model did extremely well, but what was much more important is the fact that if you develop AKI, you're at higher risk of all-cause mortality. And most of it is occurring in that first 90 days. You see the separation of the curve immediately, and I think that's incredibly important. And if you see most of this in that first 30 days, very, very important association with mortality. This was validated in the MATRIX trial, large ACS patient population, and showed beautiful validation that I think also is extremely great for us to see. Hydration, extremely important. The impact is tremendous. I don't need to tell you that you really have got to give hydration 1 milligram per kilo over 12 hours before and after. And I think it's very, very important to understand how important it is. How you hydrate the patient, this trial by our very nice colleagues, Sam Brar, who was one of our fellows at Columbia, basically what he did, and he was very interested in this, is use the left ventricular end diastolic pressure at the time of cath to see what level of hydration the patient needs. And so he guided it by using the left ventricular end diastolic pressure, and he showed, versus standard hydration, and he showed that if you did that, you reduced AKI and major adverse events. So that's incredibly important. There's another idea of this renal guard concept of forced diuresis in terms of weighing the urine, hydrating the patient aggressively, and diuresing the patient. So IV diuretics, IV hydration, and measuring the urine output and equalizing the output and the input by forcing from this PRINCE trial of a very, very high renal flow or urinary output, and they showed some interesting data from the trials. You see most of them showing a major reduction, but I'll tell you, we did a US study that did not show an improvement, but I think it's very important to think about that. The Remedial 3, where they use this, urine flow rate guided hydration compared to left ventricular end diastolic pressure, and this was Carlo Bregori, he showed better with forced diuresis, but I will tell you that I still believe that you could do an easier way, not have to put a system in there, just use the left ventricular end diastolic pressure. But even if you just use your clinical acumen, I hope that's good enough to be able to know that a patient should be able to have an important benefit. In TAVR patients and CKD, they also showed some interesting changes, but importantly, this particular reduced AKI trial, renal gallguard did not prevent contrast-associated, and in fact, it was associated with increased mortality. So it's important to understand that. And the STRENGTH trial, renal guard was not superior to standard hydration with saline CKD patients undergoing complex PCI, structural or peripheral. And I'll tell you that our US study also showed a negative. The AMAZING study is another negative study with prophylactic hydration, but look at the rates here, extremely low. These were patients with chronic kidney disease undergoing intravascular contrast administration, prophylactic hydration versus not, and they didn't show any benefit of hydration, but I could tell you that it was, they showed some issues with symptomatic heart failure, 4% versus 0 for hydration versus no hydration. A simplified rapid hydration could be used. I think one of the things is simplifying the strategies, lowering the duration, and less infused volumes. It could be an alternative to the risk of fluid overload, especially for our heart failure patients. But hydration is incredibly important. I don't need to tell you that renal function is, and using that as an important way to evaluate how much dosing of contrast media you give is a very, very good way. You could use the contrast volume to creatinine clearance ratio. Anything greater than 2 is an independent predictor of contrast-associated acute kidney injury. You could use that. And I think it's ideal to stay less than 1 to minimize that risk, and this has been shown. There have been a lot of work that has been done in contrast-sparing strategies, limiting how much you give per injection, diluting it, no side holes, using increased acquisition rates to improve your images. I've seen so often where you just keep puffing. I mean, you've got to stop that and really think about every time you give contrast media, you are really causing that vasoconstriction in those distal renal tubular vasoconstriction of the efferent arterioles. And using intravascular ultrasound, OCT, and coronary physiology testing is another way to really spare. The Remedial 4 is using this contrast sparing and contrast volume reduction strategy, where they did show an important reduction, and I think there's no question that the volume matters. The preventive treatments like statins, this is a meta-analysis, 9 trials, 5,200 plus patients, showing that you give a high-dose statin, you could reduce the incidence of acute kidney injury. But remember, these are multiple trials, only 5,000 patients at the end. You know, I mean, there's no harm, but I'm not so sure that I'm 100% thinking that this is the end-all and be-all. It's a Class 2A recommendation in our guidelines based on this. The PRESERVE trial, it shows you there is absolutely no benefit of antioxidants or sodium bicarbonate. So N-acetylcysteine, sodium bicarbonate, forget it, don't waste your time. Many did that. There is this inorganic nitrates with a trial. They used our risk score. They found in 640 patients some benefit, so I feel like I have to explain this and put this up here. It hasn't been repeated, but it was a double-blind placebo-controlled trial that showed a benefit of inorganic nitrates compared to placebo. And they showed that they could reduce CIN and reduce 1-year MACE. So I think it's one to think about. So to take home, it's important to know about acute kidney injury. The kidneys matter. We certainly don't want to cause any acute kidney injury of our patients undergoing PCI, TAVR, or any of our procedure. There's no specific treatments except to identifying the patient, making sure you hydrate and limit contrast volume and use more imaging and getting your best results without contrast media. And I think very important is, with regard to this, is that there are no true N-acetylcysteine, sodium bicarbonate, theophylline, all these other things that have been done. None of them help, but the only things that show some good result is high-intensity statins and inorganic nitrates in one trial with 640 patients, but more to come, hopefully, on this. Thank you for your attention.
Excellent talk, Dr. Mehran, and we are listening you about the CIN multiple conferences. The culprit in CIN contrast is iodine, and iodine we are using everywhere. Iodine is responsible for CIN, and iodine may cause the sensitivity reactions. So can we replace the iodine with gadolinium or carbon dioxide for our procedures?
Actually, there are important renal issues with gadolinium as well. And there are also, I don't think that carbon dioxide and all of that is the answer. That we've been down that road before, and that has not been. At the moment, this is the best that we have. The difficult issue is that we haven't been able to make progress on contrast media. I think there has to be innovation in contrast media, but I also believe now that there's going to be some ways of doing imaging without any contrast, and I think that is really the future of where we are going, and with different technologies that are forthcoming in terms of imaging and without intravascular, and I mean, look, you see with IVUS, you could do intravascular imaging without any contrast media, but externally, how could we do this without? And I think those are the kinds of things that are coming in development down the line, so that we don't give iodinated contrast media, as you speak about that so beautifully. Thank you.
Excuse me, I have one question. Can I ask you?
Yes, hi.
Yeah, can you suggest, earlier we used to use some formula for the total amount of contrast that can be given based on the creatinine clearance.
Yeah, the
so in
ratio
present
I just gave.
yeah. So what's that calculation? Because we'll have to stage the procedure if we exceed that count, that
It's the
contrast.
ratio, anything greater than 2 of the creatinine clearance to the contrast volume. That's when you start to, you really want to keep that ratio below 1. Simple as that. Creatinine clearance, you have to actually calculate that and be below that.
So irrespective of the weight of the patient?
Should be less than, well, creatinine clearance
Yeah,
uses
so
the
creatinine
weight.
clearance include that. So,
Yes.
So contrast
180,
volume.
You know,
yeah,
140 minus the age, you know, the
yeah.
Krakoff-Gault formula, or you could use any of the formulae.
So less than 1 should be the.
Less than 1 is ideal.
And more than 2 should.
More
we should
than
stop.
2
We should stop.
harmful,
Yeah,
yes.
thank you.
we should minimize the contrast for every patient, irrespective of renal function.
Yeah,
As a
we
policy,
do that.
because in
In
our
fact, in our cath lab, there's a constant someone sitting there telling us, oh, it's time, you're giving too much, So it's obvious, we're measuring it very, very closely.
Is there any-
And you really want to be, in those highest risk patients, you want to be under 30 cc's, and we do that. Dr. Sharma, do you want to comment on what you're doing?
Just to say that the CIN or AKI has become so important, the safety measure and the quality. Because they had taken the door to balloon time out because everybody is meeting those 90 minutes. So now the ACC, NCD are one of the parameters where QHIP, if you do better, you get better payment to the institution. And now they added this CIN. It's a very big. Although the first
I didn't
report
know
came, we didn't do good, but I have to show you that. I just we got, yeah. But I think it's
We
just
better
have to.
work on it, you have to bring it back to the cath lab.
Doctor, my query was about the inorganic nitrates which is recommended. What inorganic nitrates you recommend and what you use?
Well, those are like beet juice and, they come in those are the inorganic nitrates. This was a UK study. It was a very, very interesting UK study. I don't really know where you're getting that, but it's just one study.
You did mention that, I said maybe that some molecules you are using yourself.
Inorganic nitrates?
Inorganic nitrates.
No, we are not, we don't have it. We're not using it. But it's this one study that just came out last year.
You mentioned Mehran formula also there in the
Yeah,
slide.
they used the Mehran, they did, not me. They used the Mehran.
Is it different
risk
Mehran
score.
or same Mehran?
Same Mehran. There's only one Mehran in AKI, yes.
So,
It's only
they use the Mehran score.
They use the
to show
score
that it was
to
one.
show that
Yeah.
it's, no, it's not my inorganic nitrate.
Not patented.
No, this was,
Not patented.
no, this is
It's
one
not
of,
yet been published, actually, so.
this is one of the UK, they have some organ
It's a
nitrile
Scottish, yes.
compound,
Yeah,
very
it's their
complex
own
situation,
compound.
infusion was
Yeah.
given
Yeah.
with a weight based.
Do we have something like this in India? Anybody can answer?
India, we are still giving N-acetylcysteine.
No,
Everybody
it's-
getting it. I just tell you in India, everybody getting N-acetylcysteine.
It doesn't work.
Patient feels good. That something is being done.
Placebo effect.
Doesn't work.
Any difference in CIN intra-arterial versus intravenous contrast?
You're very, very good question. That's what our radiologists and this amazing study and all these people basically are saying, oh, we don't see contrast nephropathy. I said, well, you don't see it because you don't get to measure it. Radiologists just do their studies and send the patients out. And of course, the intravenous is different because we basically are going directly intra-arterial, going straight into the kidneys, obviously from the heart, whereas there's a second pass through the venous, right? So that there's some dilutional effect by the time it gets, but none of that has been well studied prospectively or anything like that, but there is all these hypotheses out there.
About the high dose statin, is there any specific statin you would like to recommend? Because rosuvastatin has been correlated with some renal
It was a
dysfunction.
3,000 patient study out of China from Han Yaling, which was extremely positive. It was a JACC publication that's what's driving that.
Atorvastatin or some other statin or specific statin
It was
which...
rosuvastatin at a high dose, 40 milligrams, yeah.
Thank you, Dr. Mehran. And as is the custom, the best dishes in the menu are reserved for the dessert. So now we have Dr. Saibal Kar, followed by Dr. Samin Sharma. So Saibal Kar would be presenting his the most learning case.
So, Dr. Samin Sharma, once again, thank you very much for inviting me. Dr. Samin called me like 2 weeks ago and said, Saibal, can you come? I said, do you have...
You are the last one.
That's right.
You are the last one.
So I said, why are you calling me there? You have all these star speakers. He said, we need some intermediate fillers for good speakers. So that's why I'm here. Thank you very much. So I just want to go forward here. So this is an 88-year-old female with known history of sarcoidosis on treatment, hypertension, TAVR in 2018 with a 26 millimeter Evolute FX valve, presented with severe shortness of breath for 4 months, prominent jugular veins, bilateral pedal edema, sinus rhythm, early diastolic murmur. Notice the blood pressure 130/42. More importantly, the patient has not slept in a recliner for 4 months and has been on oxygen. So when we saw this patient, actually was seen in another hospital, yes, here. So these are the baseline echoes. And you can see over here, the left ventricle is slightly thickened. The LV ejection fraction is slightly reduced. You can see an aortic prosthesis over there. And then if you look at the leakage, you can see that he's got a moderate mitral annular calcification, but he's also got some regurgitation, aortic regurgitation. And as Roxana will tell you in their studies, that if you do see diastolic regurgitation of an aortic valve, that means you have prostatic valve dysfunction. So this was obviously prostatic valve dysfunction. The question is, how bad is it? And then if you look at the echo and you look at the pressure half time, and you can see the pressure half time is very rapid. And so this is around 172 seconds. So anything less than 200 milliseconds is severe AI. So basically looking at the echo, you can see that this is probably a severe aortic regurgitation. Yet this patient did not have a long diastolic murmur. And why didn't he have a long diastolic murmur? Because he was in acute severe AI, and obviously the LVTP goes up, and so that means it underestimated the severity of aortic. So based on this, I thought that this patient has severe aortic regurgitation. So we did a transesophageal echo, and what you see in the transesophageal echo in the LVOT view, what you see, number one, you can see the valve is well placed. There is no perivalvular leak. You can see one of the leaflets is clearly thickened. And then you see an eccentric jet arising from the middle going towards the LVOT. So whenever you see an eccentric jet going backwards, that means one leaflet is restricted and the other one's moving normally, causing severe aortic regurgitation. So our diagnosis was this is severe bioprosthetic failure due to severe aortic regurgitation. Now this is the transesophageal echo at 3D, and this is very important to understand because you see the valve, and what you see is a diastolic regurgitation within the valve and nothing outside it. So this is truly intravalvular leakage. The next thing that you see is all the three leaflets are moving, and none of them are restricted. In fact, one of the leaflets is actually thickened, but the left and the right are moving. And the third thing, which is even more important, is you look at the commissures. If you try to see this, these commissures are right at 12 o'clock position and 5 o'clock position, and what you see on the left side is the left coronary artery. So it's very good for me. I looked at it and said, oh, wow. So the commissures are appropriately aligned, and the coronary artery is just between the two commissures, but the sinuses look very small. So the question is, what do we do with it? So I did a coronary angiogram, and this is what the coronary angiogram looks like. Look at the right coronary height. It's just above the neosinus, because this is an evolute valve, which is a supraorbital valve. Look at the right coronary artery rising just above the sinus. And then if you look at the left coronary angiogram, you see the same, that there's a very small distance between the neosinus of the supraannular valve as well as the left coronary artery. So you'll get fooled and say, oh, your framework is right down here, so you have a very good height. But no, the sinus is right up here. So the question is, what do you do for this patient? So we thought of TAVR and TAVR. Consider open heart surgery, removal of the TAVR and surgical valve replacement. And Dr. Ban yesterday told us that the mortality is very high. Continue medical treatment since it's too high risk for either of the procedures, or just consider hospice. So how many would consider surgery and how many consider TAVR and TAVR? In the 88. You would go for TAVR and TAVR, okay? Anybody for surgery? You'd go for surgery. Okay. So you would go for surgery, you'll go for TAVR and TAVR, and do you want a certain valve? Are you concerned about this case?
Concerned about surgery is...
No, TAVR and TAVR. You're not worried. You'll just go with... What valve will you use?
Because coronary height is not that much, so you have to be careful. And it's already a self-expanding valve inside. So it's a newer valve.
This is an evolute valve?
Yeah, accurate neo.
You'll use an accurate neo?
Yeah.
Okay. Well, we don't have accurate news available in the US anyway, so what would you use, Samin?
I mean, if we take a thing together, it clearly looks like that all is with the intravalvular. It has to be with the leaflets and the dysfunction which you are having. And then you saw the coronary heights. So you can always take a balloon expandable and implant it low.
Okay.
Yeah.
So you'd use a balloon expandable and implant low. George, what would you do? Or Roxana? You do the same? Okay. So we did a little bit more of an analysis. So what we did was, we looked at the distance between the coronary of the valve versus the coronary, within the right coronary artery, and that's 3.8. If you look at the left coronary artery frame and the left coronary ostium, it's 4.2 in the best case scenario. Sometimes it's 4. And you heard yesterday's lecture, anything less than 4 and 3.8, you have a concern about coronary obstruction, okay? Now you look at the CT. Your first reaction is, oh, look at the CT. Its frame is here and the coronary is right here. But look at this blue line that I've drawn purple. That's the neosinus. And the coronary is only 6 millimeters and the leaflet is long. So if you just put this valve in, it's going to shut it. So whatever you do, even if you put the valve low, even if you put it very low, what was going to happen? This leaflet was just stuck up, right? So now what do you want to do? So the neosinus is less than 9 millimeters. So you still will go for a valve?
Then you go for the left main protection. Then you do with the protection.
Okay, so basically, these are my options. Challenges this case was, of course, is a supraannular valve, very narrow sinuses, low coronary height, and all these make coronary occlusion very high, right? So we see he fulfills all the criteria of coronary high obstruction. So the question is, what do we do now for this patient? Consider leaflet modification basilica, provisional snorkeling stent deployments with both coronary arteries. What would you do? You do a basilica, okay. And you, Samin, what would you do?
I still will. We actually presented that case, 2 years ago, but you were there with the valve conference. We did a both protection of the right and left coronary arteries. So that is possible. Now, basilica, the question is you do by both sides, bilateral, basilica can be done. And of course, now the shortcut device is available, which you can now cut it. Basilica is a little, very intense procedure, require a lot of time. But now we have the kind of scissor, and you can cut the leaflets, will be available very soon. It's been approved by FDA. So that is one of the way. And of course, I mean, clearly the coronary obstruction is the most common region, even in patients with high risk, but if they are viable, they go for surgical explant. So that clearly is and we have sent patients 86-year-old, because we found that coronary obstruction was so high, bilateral coronary obstruction, we knew that will be very tough to manage, and we sent the patient for surgery about 2 years ago.
So, George, what would you do? Roxana, what would you do? What would you do? Snorkeling? Okay. So you'll do and you'll do bilateral snorkeling, right? So you're going to. So basically, what you're saying is that they're going to put 2 guides into both the coronaries, right? You're going to put 2 stents placed inside the coronaries, and you're going to pray. You know that you'll pray and say, "Hey, Jesus, please," and then you're going to put the valve up, and then they're going to arrest, and then you're going to put the stents up, right? And you're going to put it up, okay? So that's the way of doing it. Now, basilica. Now, basilica is a method of cutting the leaflets. Average time to do a basilica for a single leaflet is 45 minutes. This patient has a right coronary artery which is 6 millimeters and the left coronary artery which is less than 6 millimeters. So you have to do a dual basilica. You will cause severe AI when you cut the first one. You will take another 1 hour to do another one. By the time you do that, you'll have a postmortem death. So basilica obviously was also not our patient. The 88-year-old lady who's orthopnic sitting in a chair for 4 months. So what did we do? We took this patient for the shortcut procedure. This patient was actually one of the first continuous access patients done recently. And what this is basically it's a dedicated leaflet splitting device, as Samin mentioned, and basically slices each leaflet intuitively, and you can actually control it because you go over a wire, you cut each leaflet. So what I'm going to show you, the procedure is that you advance your wire into the LV, and then you advance it, and then you cut one leaflet, you turn around and cut the second leaflet, and then you pull out the whole thing, and then over the same wire, you put a valve in. So the whole thing can be done in less than 35 minutes. So this is this is the procedural steps. You can see, I'm just showing you animation-wise. You advance the safari wire. It's over an 18-French sheath. You advance the system. You just like an evolute valve, and then what you do is that you desheath the device, and when you desheath the device, you'll have the splitting elements which will come out. And then you can orient it under echo and fluoro to make sure that it's in the middle of the valve, just in front of the coronary, and then you advance it. And when you advance it, it won't go over the valve. So what you're going to do is you're going to flex the catheter. And as you flex the catheter, it goes over the valve. So now we're going to flex it, and then you advance it down further, and then it's at the base. And then you activate the cutting element, which is below. You see that there's a cutting element which is going right through. It's going to pierce the leaflet, and it's going to touch the other arm. So when it does that, you know you've got the leaflet. And then you just gently pull the whole system back, and it slices the leaflet. And once you slice the leaflet, you get severe aortic regurgitation, worsening aortic regurgitation in this case. And then what you do, you clockwise the whole catheter by 90 degrees. And then you go and do the same thing over the right coronary cusp. And then once you like it and it's done on both sides, you can recollapse that positioning arm, which I'm doing now. We're actually repositioning the whole thing, bringing it back further. And it's very easy to resheath this device like this. You pull it back, and you keep the wire in the ventricle, so you're not losing any access in the ventricle. And then once you resheath the whole device, it just comes back. You make sure that you've cut both the leaflets in the right spot, and then you get your valve ready, and then you deploy an evolute valve, and you can see what's happening in systole it's blocking, but in diastole there's good flow, because the framer is stemming up, and then you get good flow. So what we did is, this is the angiogram, and watch this. You'll see, how did I know how to go forward? So what I did is I put a guide catheter and a wire into the left coronary artery. So I knew where the left coronary artery was, and therefore I went parallel to that, and therefore I managed to know that that's probably the left coronary cusp. And then you can see the arms are activated, and then you start to pull it back, and as you see them pulling it back, and it just gives away, and then you show by TE that you've actually split it. Then you rotated it on 90 degrees, and I caught the right coronary cusp and did the exact same thing. The patient went to severe AI, and I'll just show you the picture. So this was, look at it. Can you see on the right screen, the leaflet is torn, and you can see that leaflet flopping around and flowing right into the coronary artery. So that's the left coronary cusp, which is split. And then you do the same for the right, which is more difficult to visualize. And this is what the TE looks like. You have severe aortic regurgitation now. The pressure drops a little bit at this time. Some patients, it can drop further. And then we went ahead and put a valve. So where do you place the valve? And we usually place the valve in the fourth internodal space. And you count the nodes, and you make the upper frame of the sapien to be at the fourth node. So that allows you space above the coronaries. And then you deploy it, and you can see that it will shorten from below, but in the top it will remain constant. And then after deployment, you can see over here, you can see the valve is deployed, and what do you see in the coronaries? You see perfect flow in both the coronary arteries. And you can see that the leaflets are actually much higher up, but because they are split, you can see a normal flow to the coronary artery. So this patient actually did very, very well. This was the 5th patient in the world to have a dual split on an evolute valve. So this is a good case to show it. So this is the final TE. You can see there's no aortic regurgitation. The valve is deployed correctly, and the mean gradient is only 3. And this is the patient is off oxygen, can lie flat for the first time in 4 months. The FDA, as Samin mentioned, just approved this device in September 2024. I think Dr. Roxana Meron was on the DSMB of the study. Thank you very much. With expansion of the use of TAVR in younger patients, there will be a need for leaflet modification for TAVR and TAVR procedures. And this is going to be a tsunami in the next few years. We're going to have all these valves coming back, and we have to have a solution to treat with them. Thank you very much.
Any question? But that was a great case, I would say the grand finale of the conference. And just to say this shortcut, actually we approached that. You know how much will be the cost? $15,000.
I know.
The company is posting of $15,000. It will be extra cost to your tower procedure.
But Mount Sinai is a rich hospital,
Yeah,
and
but-
so is this hospital too.
But yeah, I know, but you start using it, you definitely will make them bankrupt. But yeah.
Cybil,
yes,
quick,
yes.
fantastic case. A quick question. When you cut the valve leaflet,
Yes.
do you rapid pace the ventricle to try to minimize the AI?
Yeah, so this is a very good concept that when you, as you know that the way to decrease aortic regurgitation is causing tachycardia. That when you get tachycardia, you decrease the diastolic filling period and you can reduce AI. So what we did is that we cut the leaflets, but we paced at, I should have mentioned that, paced at 100. And when you pace at 100, you decrease the diastolic filling period and you reduce the AI. Yes. I'm sorry I didn't mention that. And then when we deployed the valve, I did the same pacing rate.
All right. I think with that note, clearly we, the 2.5 day session marathon, now we'll ask Sanjeev to make the concluding remark and with Jitendra both, and we learned quite a bit. And I know that the next time faculties will have some more lectures because that's what people want to see or hear, those presentations, but has been a tremendous. This we did at such a large level, high this time, but definitely will continue to improve in the future, bringing same 6 faculties from United States. Sanjeev and Jitendra for the concluding remarks.
Yeah, thanks everyone. And first of all, I would like to thank our international faculty, Dr. Jagat Munala, who has already left, Dr. Sean Pinay, Dr. Sebelkar, Dr. George Dengis, Dr. Roxana Mehranan, who could travel all the way from United States for this meeting for these 3 days and made this conference very rich. And we have been immensely benefited by their contribution. And next is our national faculty, who have also traveled from all over India and given their insights and shared everything with us. And the other thing is, on the day 3, Sunday, and being a festival day, Karwa Chauth, I can still see so many faces. So I'm really thankful and grateful to all of you for active participation. And we have seen a very active discussion in most of the international faculty lectures. That is very encouraging for all of us. And then next, I would like to thank our sponsors first, and then our sponsors, there's a long list. I would like to name on this as a chronological, Abbott Vascular team, Boston Scientific, all of you are there. Our Merrill Life Sciences, Medtronic, Sun Pharma, Novartis, AstraZeneca, Thermo, Philips, Edwards, USV, Viva Scientific, Torrent, Intas, Eris, Mankind, Bearzydus, Pfizer, Lupin, Boehringer, Erzo, Servier India, Well-Run Pharma, and Eucardics. So all of you, thank you very much for sponsoring our event and making it memorable. And I would like to thank our marketing team, led by Nitesh, Vikrant, Ashish, and whole team. They've done a great job. You can stand up, all the marketing team guys. They've been there for last many, Manish, I can see. They've been there with us for many months, and we have been planning and executing everything. Dr. Prajesh Prakash from M Floor and Rajan from administration, all have been there in coordinating and doing everything on their part. It's a wonderful job. And our AV team, Ujjwal Bhatia, JTech team. So all of you guys did a great job for last 3 days. And then our own faculty from Eternal Hospital, Jaipur, our cardiac sciences department, our all faculty, they were always there for us. And thanks for making more. If I forgot this, any name, then. So thank you very much. And now I will pass on the mic to Jitendra for saying the final words.
I think we should thank our delegates who made this possible. We actually at Eternal Hospital, we are known for good gathering conferences. Otherwise, these days it's a problem to get audience. You get speakers, but you don't get audience. But this is all love, affection, and respect for Eternal Hospital and for our team that you all make here. And we hope that you are going back with some good take-home messages. Thank you, our international faculty. You were the stars of this conference, and we look forward to invite you every year whenever we do such things. And at last, a big round of applause for Sanjeev, who did all this scientific program and made everything possible here. Thank you very much. Looking forward to see you again next year.
Thanks, Samin sir, Manju ma'am, for being there all the time with us, encouraging and motivating us to do it. Thank you very much.